Good morning, everyone. My name is Adolfo Mendez. I'm a special counsel to the Attorney General, and I'll be moderating this morning's the first two panels. And I'm pleased to be sitting with so many experts on the subject matter that the AG previewed. We'll be getting into the underlying dynamics and the interplay between ACEs and public safety. We'll ask our panelists to express and share with us the biggest obstacles that they encounter, and then we'll try to get at some solutions. And so that's the structure of our conversation today, this morning. And I think we'd like to start with our medical doctors, and let's start by talking about the underlying dynamics, and we can get into a little bit about the brain science of it, and I'll get us to a slide about that. So, Dr. Lindsay?
Yeah, no, I'm happy to explain this graphic, and I think it's really important to understand how adverse childhood events impact the developing human, and then later the behaviors that they engage in. So this pyramid exemplifies the fact that when people experience adverse childhood events, which include traumas, so things that are perceived as life-threatening, but also things like poverty, unstable housing, unstable food resources, those experiences have a direct impact on how that brain develops. And if you think about it, we all have an alarm response in our brain. It's like a fire alarm or a house alarm. It's intended to keep us alive in a state where there truly is an emergency. But that can be hijacked by certain types of experiences, like adverse childhood experiences. And when that happens early in life, it has an imprint on the brain where that alarm response becomes easily triggered, and it can happen hundreds, if not thousands of times a day. So if you imagine sitting here trying to listen to this talk, and the alarm for the fire system was to go off, we could all sit in here and try really hard to listen to this conversation, but it would be pretty difficult, if not impossible, to sit in your seat and listen attentively. Your nervous system is going to become activated because you're going to attend to danger. So that's happening in the brain of someone that experiences an ACE, and then if they're experiencing chronic ACEs, it becomes an ongoing pattern, which then is going to disrupt how people engage and are able to access education. So how they're able to socialize with their peers, how they're able to regulate their emotions and make logical decisions. That, of course, is going to impact the likelihood that they're going to engage in high-risk behaviors. So you can imagine if you're in a constant state of that alarm going off, it's really uncomfortable. So this explains a lot of why people early in adolescence will engage in experimentation with substance use. And we know that the longer we do that, the more likely we are to develop a substance use problem. That's also going to increase the likelihood that people will engage in other behaviors or other environments because they can't tell the difference between what's safe and what's dangerous, which is going to increase more trauma, which then starts the cycle over. And then inevitably, this is going to result in all kinds of physical and mental diseases, disability, social problems, criminality, incarceration, and then a shortened lifespan. We also know that this impacts how genes are expressed. So the epigenetic arrow here, it's like if our genes are hardware in a computer system. It defines the boundaries of who we are capable of being as a person. But the environments that we experience early in life, those are like the software or the Windows system, which tells us how we're going to engage with the environment, how we're going to behave. So those things interact, which means we might have some genetic vulnerabilities. It could be cancer, could be heart disease, could also be schizophrenia or bipolar disorder. substance use disorder, those things can get activated. And then they can also carry over from generation to generation. And so that's when we can see this intergenerational transmission of the ACE events. It can carry within a family or a community or an entire area, like what we're experiencing here in New Mexico.
Are we predestined? Like, if you have ACEs, like, are you stuck
Absolutely
in that
not.
pattern?
Absolutely not. In fact, we are highly resilient as creatures. The more ACEs we experience, the higher the risk gets for having a negative outcome, some kind of disease or disability associated with those experiences. But by and large, we're very resilient. So people can absolutely recover from these things, and their brain can learn what's necessary to start to regulate itself.
And I was remiss at the beginning. Would you please introduce yourself?
Yeah, I'm Larissa Lindsay. I'm a clinical psychologist, and I'm the executive director for behavioral health clinical services at UNMH.
And Dr. Stoffel, would you like to add anything? There's a slide on with the brain, if you'd like me to go to that, and you can just talk a little bit about
I mean, I can talk a
brain
little.
science.
Oh, yeah. Dr. Lindsay is probably more of an expert
sorry.
on brain size.
Go ahead and introduce yourself as well.
Sorry about that. I'm Chloe Stoffel. I'm a pediatrician at UNM, and I'm also the medical director of the Adobe program. We see kids that have been in the juvenile justice system primarily, but we see a lot of intergenerational trauma, and we see the concrete after effects of the ACEs that affect these families. And then I'll also just add, we talk about early childhood adverse events, but I think the thing that we always think about in the Adobe program anyways is the way that it impacts the entire family. This is an intergenerational problem. And so you can't simply address problems in children without addressing the entire family and trying to stabilize them. I think when it comes to looking at behavior in like a concrete way, I think we Dr. Lindsay talked about the hypervigilance that can happen once you reach a certain threshold of trauma-induced stress. And so that manifests as like a preschooler who can't sit still, can't pay attention, is then disciplined and told that they're a poor student, a bad kid. And then they go on to internalize that, and they may start participating in, they may ditch school. They get the message that they don't belong there, they don't get supported there. And the schools don't always have the resources to support them either. So we tend to see these kids after they've had a lot of educational interruption, and they're on a pathway into incarceration as a juvenile, which we know puts them at much higher risk of incarceration as an adult. So the thing that I always keep in mind is that the kids that we see physically don't have the hookup in their brain to necessarily make the most informed, thoughtful decisions. Their anatomy just isn't there, and we know the effect of trauma can impact the executive function of the brain. So the ability to make well thought out decisions and understand the consequences of behaviors.
Thank you. And Dominic, would you introduce yourself and then talk about, from your perspective, the underlying dynamics and the interplay between ACEs and public safety?
Sure. I'm Dominic Capello. I'm the co-director of the Anna Age 8 Institute. We are a program of NMSU. We were funded 5 years ago by the state legislature to be the state's ACEs prevention project and work in 33 counties. And I think that we've taken on, this talk is really important. It's really complicated stuff. This, I was telling Alfonso, this can be a 16-week university course, and we would just get started. But it all seems very abstract if you're sitting here, and I used to sit there and listen here about 10 years ago about ACEs, and I think it's important to remember that we're just talking about kids. And if you're wondering, Anna Age 8 Institute, what kind of a name is that? Well, you should know who Anna was. So 5 years ago, I was working at CYFD with Dr. Catherine Ortega-Courtney. We were not in the field. We were in the central office of Child Protective Services, and we were collecting data. So all 33 counties would send us information. As you can imagine, when the phone call came in and there was suspected abuse, and did that turn into an investigation, and was it substantiated? And you can imagine the process of when there is suspected abuse. So we worked in this office, and when you work for child welfare, it's tough work. And the news came in that there had been a child that had been killed that was involved with child welfare. And Catherine and I, we would hear this, unfortunately, weekly about children, but the story came out that this was a child that had been in and out of child welfare 8 times. And you need to know that before you could take a child out of a home, a lot has to happen. And when you do take that child out, there are a lot of assessments of the child, of the mother, of everyone in the household. So to have a child go in and out 8 times is very unusual. And when the child was returned, the child was kicked to death by the mother. And there was uproar. This is a very big case a while ago. And we were very upset about this. We thought our system, what's wrong with child welfare? How could this even happen? And so because we're researchers and we believe in data, we said, what's wrong with our system? Why aren't we protecting our kids? And so we went to upper management. I mean, we were the research unit, and we told them, we've got to go back to the research here. We've got to figure out what went wrong, so there's not another case like Anna's. And they listened politely and did nothing. And so we were very upset. And so we wrote a book called Anna, Age 8. And it was about adverse childhood experiences. And we thought it would be a book about pointing fingers at CYFD. But as we did more research, we realized that this problem was so much bigger than child maltreatment. It was adverse childhood experiences. It was every child at risk to varying degrees. And so this is when you start talking about ACEs, you're not talking about the kids at CYFD or the kids on the other part of town. ACEs appear in households of all income levels. But if you don't have resources, it's going to be very difficult to address ACEs. I would like to say then that, and this is for those of you who are change agents in this room, and probably most of you are, we were just 2 people, at CYFD, very low down on the food chain, but we felt this was injustice. And so we wrote a book, and we were very nervous about it. We left CYFD, and a state legislator saw the book and read it and said, these recommendations to look at ACEs in a very different way across New Mexico, to use data, to use research, to see the big picture. I'm going to get you the funding, and you're going to get an Anna Age 8 Institute to do the work. So the point of this story is really to say, this is really complicated stuff. This is really important stuff, and that change is possible. We are the only state in the United States with a statewide system of data-driven ACEs prevention. And we have a long road to go. And I was thrilled to be asked to be part of this because our partnerships with the Attorney General and other leaders is absolutely critical here. So I think I got off sidetrack from what you wanted, but if you can show the next slide, and then if we can go to your slide, if that's all right, and then I'm going to stop talking.
Well, then we can go back and react.
We joked a little bit. I said, if you need a signal to make me stop talking, just pull your ear. So if you see him doing that, I'll stop. But I'd like to end with this, is that, and I think it's already been shared pretty well, in that ACEs, and this may be hard to read, but trust me on this one. If you think of a public health or a public education or a public safety problem in New Mexico, you can track most of it back to ACEs and trauma and untreated trauma. So that's, I believe, why we're in this room, because if we don't acknowledge this, and there's much more to talk about, I'll stop now and I'll talk a little bit more about what we're doing, but we have to think very differently about ACEs. I think when we talk about prevention, and I'll talk about it a little bit later, it's probably not what you think. It's really big picture stuff, and we're going to need every change agent in New Mexico to be with us in this campaign.
No, that sounds good. Thank you. And Matt, why don't we introduce yourself and then talk about the underlying dynamics, and then let's go down the line and kind of react to this slide. But go ahead and you talk in your work, talk a little bit about your work and how the interplay between your work and ACEs and trauma and public safety.
Sure. So yeah, I'm Matt Probst. I'm the Director of Rural Engagement for the UNM Office for Community Health. So good to see so many awesome partners out there. So I've been working on this for almost 49 years, because that's how old I am. And it started, first and foremost, I'm many things, but first and foremost, I'm a New Mexican. And as a New Mexican child, I suffered from 9 out of 10 ACEs, adverse childhood experiences. So there are 10, and I endured 9 of them. And the only question I won't tell you is I won't answer is which one I didn't. So it leaves a little bit of mystery in there. Unfortunately, I'm not unique. Many of our kids average many ACEs. And as Raul said earlier, there was one step missing, right? My wife is a school teacher. I'm a primary care provider, medical provider. But there was one step missing from what he said, and that is a common spot that brought me and Sheriff Lopez together, our sheriff in San Miguel County, as change agents that Dominic described for one mission to end childhood trauma, and that is death. From the classroom to prison to dead. And so as 2 youth mentors that you guys might not know Vegas too well, but if you do, it's East and West, okay? It's a huge rivalry, maybe the biggest rivalry in all of New Mexico when we talk about athletics. And so I coached junior wrestling on the east side of town, and Sheriff Lopez coached on the west side. And we realized that, our kids eventually, we are in the same district, right? Eventually, the day comes where they have to wrestle against each other in middle school and high school for state championships. But at the youth level, they didn't need to wrestle against each other. We said, let's combine our youth teams. I bet you we can win some national championships. And we did. And so practicing together and traveling the country and winning some national championships, one day after practice, he says, Matt, I could tell he was really hurting. He says, Matt, there's got to be a better way than arresting these people who are my people, my own family, my own folks I grew up with, right, classmates, arresting them over and over again until they die of an overdose or a violence or suicide or some outcome. There has to be a better way. And at the time, and some of you may have seen the Providers documentary. That's a story, a documentary about rural healthcare in America that I'm in. And so if you watch that, you get to see my whole, story. Everybody knows now, the background of who I am. It's out there to be seen. My sister was really struggling at that time. So I was trying everything I possibly could to try and keep her alive as she battled meth. And this was, 12 years ago. And I said, it's called trauma-informed care. And it's all the rage in Europe. And it's about, basically it's about, providing opportunities instead of punishing people for being sick. And instead of making it much harder for them to recover, giving them more and more barriers, taking away their licenses to drive, their ability to work, their, that's the system that we were in. Back to his experience as a sheriff, arresting people over and over again until they die of an overdose. And there's got to be a better way. And it's existed for a long time. And, when it comes down to it, I think that the biggest thing I could say as a New Mexico kid, that last one there, 50th for adverse childhood experiences. So we're dead last. And I say this, I don't use the word dead lightly. That's the root cause that leads to death. And so many deaths. I'll be celebrating my 30th anniversary at Pojoaque High School, where I graduated next month, and where Ben Ray, U.S. Senator Ben Ray Lujan, and I grew up together, where half of my classmates won't be there because they're dead. And so there is a better way. But it will take a revolution like that Dominic can speak to us. It will take all of us, cross-section collaboration. And I think the biggest thing that it'll take is that right now I see all these siloed systems, if you will. We just heard about CYFD, for example, but all these siloed systems, education, healthcare, public safety, et cetera, with one common thread. They're overwhelmed. It's such a big problem. And I'll hear, it doesn't matter if it's teachers, law enforcement folks, healthcare people. Well, we're never going to get any better until they do better at home. The parents got to do better for these kids. Well, this is not the kid's fault. It was never my fault. I didn't earn 9 out of 10 ACEs. The only good it did for me is it made me resilient. I'm still here, and I can take a punch, boy, but I shouldn't have to. And the kids shouldn't have to. And so together, instead of blaming and saying, well, the parents got to do better. Well, parents are dead in prison. Grandma's doing the best they can. They're facing social adversity and vulnerability. The roots of being a New Mexican is that it takes a village to raise kids. We are that village. And so we can't leave it anymore that, well, we're not going to do better education-wise or healthcare-wise or whatever-wise until the parents do better. We need to step in as youth mentors, as experts, as community members.
Thank you, Matt. And right away, I think we're seeing how real this is, right? How close it is to all of us. So thank you for sharing those thoughts. And you started to get into some of the obstacles that we're confronting as a community. And I think that maybe the obstacles can start to explain why we're this. But why don't we go down the line and talk about the biggest obstacles you're confronting? Dr. Stoffel, you want to start? And maybe like, are they tied to like this being dead last, right? For adverse childhood experiences.
I think I can break down the barriers to two main ones, and I think they come from the same place. When we look at all the things that we don't have, all of the high-risk factors that we do have, I think we're operating from a place of scarcity. And all these different programs would love to collaborate. They would love to be secure in their funding. They would love to be able to offer all the resources in the world, but that's not the way we're set up to function. We're set up to be a little bit adversarial when it comes to the scarcity of funding. So I think in the world looking at trauma, there's definitely a drift towards strengths-based, abundance-based thinking. And so I think that's a shift I'm trying to make in my mind too when I look at my patients. And I look at their resilience, of course, the strengths that they've developed, and trying to honor that and trying to find the strengths in all of our different programs, but it takes funding. It takes secure funding. And especially, I'm so lucky to be up here. I'm at UNM, I have sort of a platform, but I think about all of those smaller community entities where you have people that are experts. I think, look at my patients as experts, but in these communities, those people are the experts. They need funding. They need people to help network and make sure that there aren't barriers to the resources that they have too.
Dominic?
Yeah, can I get my favorite slide?
Is it the next one?
Yeah.
Yeah.
Yes. When you come and talk about ACEs, it can be very depressing, and people can feel as though, we've been having this conversation for decades and nothing is changing. But the good news is it is changing here in New Mexico. So our whole approach is radically different from any other ACEs prevention project in the United States. So because we're a university, we work with frameworks, we work with models. And so if you want to make change in a society, you make change on 4 levels. There's the individual level, there's the household level, there's the community level, and then there's the societal level. That means policy. That means city, county, state government. 4 levels. And you have to make change and have interventions for all 4 of these areas. ACEs prevention, which started back in 1998, that's when the study came out by Dr. Folletti and team. when he was looking at, does what happened in childhood impact you as an adult? And it was radical. I mean, it was, anyone who read that would have thought, this is the wake-up call for America 20 years ago. And that study came out, and it just faded away. And for 20 years, there were people who said, we have to look at ACEs. We have to look at what's happening to our kids, and then what happens to them as adults. And what people did was what they could do without any resources. They had workshops, they had seminars on the brain, all very important. But that wasn't going to change society. That wasn't going to change a city or a county or a state. You have to have information, as we're doing right this second, but you have to make structural changes. And so our model, and the initiative is called, our initiative is called 100% New Mexico. And we use that term 100%, which means we're all in this. Every child is in this. No child is out. No family is out. Everybody's in. And to make this brief, I could give a long speech on this, but I have to introduce you to a term. And this is a term that's used in the university realm, in public health. It's not used often with the public. It's the social determinants of health. And it's probably one of the most important things we could be talking about if we want to make changes. The social determinants of health mean what determines our children's health? What determines our children's safety? What determines our children's education? And then ultimately, what determines the quality of all of our lives? And those would be 10 vital services. So what you're seeing based on research is, what do families need to be successful? What do families need to create a safe place? What does a city need to make sure that everyone feels safe? If you go back to families, and we know this from many of our interviews, they need what we call the 10 vital services for surviving and thriving. And the 5 services for surviving the month would be medical care, behavioral health care, food security, housing security, and transportation. If our people don't have access to these 5 services, we're not going to do anything about ACEs or public safety. It's the long list of every problem. These services have to be available to our people. Now, I would like to talk about thriving, not surviving, but you have to survive before you can thrive. And parents need parent supports, early childhood learning, community schools, youth mentors, and job training. Again, I could talk for hours about this, but this is called our model. This is our framework. We are in 18 counties right now, working with partners, building coalitions. And this means we work with city government, county government, the health councils, law enforcement. And so again, I'm going to stop now, but I'm so thrilled to be here, to be invited to introduce you to this. So if you're sitting here thinking, man, ACEs, there's nothing we can do. It's impossible. That's not true. If we can create services that are accessible, we can change New Mexico from being rated 50th to be rating first as the best place to be a family. But this is the work we have to do together. We have to unite. And I love the percentage 100%. Well, and people will say, well, so this coalition in the county, who should be in it? Everybody should be in it. 100% should be in it. There's a role for everyone in this room in this initiative with all your insights and your expertise. So I'll stop, but we have the model. And I wish this wasn't true. I say we're the only state with a model, a data-driven, university-sponsored strategic plan. We're the only one with that right now. I wish 40 other states had this. They don't yet. They're talking, but we actually have the ability to implement this and lead the nation in ACEs prevention.
So, thank you. Yeah. So, Dr. Lindsay, where are we now? Like, what obstacles are you confronting in your practice in addressing the traumas that we're seeing?
Yeah, I fully agree with my fellow panelists that I think I could definitely talk about specialty services, the different types of interventions that help people recover from trauma, substance abuse, mental illness. But people can't access that, not just because of a lack of availability. They can't access that because they don't have the security and the safety and the stabilization in their life. So on Maslow's hierarchy of need, if people aren't able to feel safe in their day-to-day, they don't know where their next meal is gonna come from, they can't access stable housing, they're not going to be able to access and take advantage of the interventions that might be necessary for them to truly recover. When we talk about trauma recovery, the vast majority of people, about 70%, will recover naturally with social support and time, that they don't actually need direct intervention to make positive changes in their life, that we all have that innate capacity towards resiliency, towards health. But until we have these kinds of system supports, until people can not feel that shame and the focus on their deficits, they're not gonna feel that they're not gonna be able to take advantage of what is available. So I think that it is important that we focus on building that bottom of the hierarchy up. That once people can access those types of social supports, and that it's inherent. It's not something that they have to be actively engaged in treatment for. So for example, all of my patients that I serve across the behavioral health system, and including the work that we're doing now at MDC, at the detention center, they would all benefit from really comprehensive case management or having a peer support connected to them and their family to help navigate the system, to get to appointments, to call Medicaid and schedule a ride and be successful getting to that next level of care. But we require that they be actively engaged and connected to a treatment provider and achieving goals to be able to have that kind of support in their life. And not everybody starts there. In fact, the majority don't start ready and willing to engage in treatment because they're just trying to survive the day-to-day. So it would be like if we were having an epidemic of cancer in our state, requiring that people be in remission before they can receive cancer treatment. So we're doing that to our society when we require people to be sober before entering a shelter. We require people to already have achieved some level of abstinence before entering any kind of residential or IOP treatment center. When we require people to be able to access their own ride and make it to that appointment. Those things are significant barriers.
Sounds like there's it's illogical, right?
It's illogical.
Right, to have requirements that are
Yes.
unmeetable,
Yes.
unattainable before folks can get that. Matt, how about, I know you'll have a strong rural perspective on this. What are some of the obstacles that are getting in the way of this, getting these services to people to intervene on ACEs?
Yeah, I think it's on both ends of that spectrum and everything in between. Hence the phrase 100%. But again, the beauty of rural New Mexico, in the provider's documentary, I say there's so much beauty here and there is so much pain. And that's the reality, right? And that's not just a rural issue. That's not just a New Mexico issue. That's the human condition is what one of my mentors, what Dr. Stoltz taught me when I was fresh out of UNMPA school. And so how do we address the human condition? It's pretty simple. It goes old school. Like I said, it takes a village. It's neighbors helping neighbors. It's all of those things that we thrive on in as a people, as a rural people. And so, that it takes systems that are inclusive and equitable. And so I'll start with on the challenge side of it. The first challenge is when it's like, well, no, this is the answer. I own the thing, right? It is again, so that just goes back to one of our biggest challenges, especially in northern New Mexico, where I'm from. I can say it. I call it the lobster pot, right? We just pull each other down because somebody's trying to get theirs and say that they got the thing, right? Instead of that collaborative effort It could be that they're competing for funding. It could be competing for what Dominic calls the hydras, right? Greed, envy, apathy, something, that they're trying to get the bigger piece of the pie. But again, the New Mexico way is not that way. The New Mexico way is feast day. Who's been to feast day? Everyone eats. Everyone is welcome. That's what it is to be a New Mexican. There's no better visual I have than feast day at Nambe Pueblo. So that's how we need to be looking at it. And so I think that's from a large system perspective. I think when we say equity and inclusion, again, so much of what will come in the legislative session as we're preparing for that, call this kind of an interim type of a preparation, is that the systems currently exist not for the bottom 25% of the population, right? How do you do something revolutionary like go from dead last to first, which is a vision we have now, right? In New Mexico, saying we'll be the healthiest state in the country. How? Well, if you could, from a data perspective, raise the bottom 25%, provide opportunities to the bottom 25% of folks in New Mexico, you could make a significant impact. You could on any of these vital services. And, yes, there are 10. In our county, we have 15. We had 14. We just added a 15th. Because in this public safety so Sheriff Lopez leads the public safety action team. That's one of those intersections we're looking between law enforcement and healthcare. We have history and culture. These are generational traumas, guys. It didn't just happen to me when I was a kid. It happened to my parents, to my grandparents, to my great-grandparents, right? And so we're breaking generational trauma and understanding our history and our culture, the things that make us who we are, that we can have pride in, not just our pains. So that was a very important one. Media. And not just, the news anymore and 540 KNMX AM radio in rural New Mexico, social media and the access to that, the goods and the bads from that. Economic innovation is one of our action teams, and that's where the Chamber of Commerce and others get involved in that, because that's a huge part of what we're talking about, and having opportunity, right, to make a living wage, to thrive in your own local community and not have to move to Albuquerque from Vegas. Okay, so there's that. And then the newest one we have is socialization and connectivity, not just digital connectivity, but getting people together. Yes, we lead the country in suicide rates of young people and overdose rates of young people. But one of the steepest inclines we're having of suicide rates is with our elders, with our ancianos, because of isolation, right? And so socialization and programs that we can socialize through social media and in person, that is also a really important thing to give folks hope.
Thank you. And it sounds like we're starting to get into solutions. That, Dr. Lindsay, you shared with me some information about the Rat Pack, right? Like the study about like individuals in isolation versus individuals together. Would you mind talking a little bit about that in relation to what Matt just shared, but then getting also into other solutions you think, and then we'll go down the line talking about solutions.
Yeah, no, there was a very interesting study that was done in the 80s and 90s, where they were really trying to hone in on what causes people to become addicted to substances. And prior to this set of studies by this man named Alexander, they believed that if we just expose people to a drug and we do it enough, that they will become addicted, that there's something inherent in the drug itself that is the problem. So if we remove people from the drug, or we remove them from the community where they have access to the drug, we're going to stop the addiction problem. Well, they evaluated how we made that determination, and we came to that conclusion as a scientific community, because we're using animal models, and we were putting rats in, were isolated cages, and we were giving them a bottle of water or food option, and something that was laced with heroin or alcohol or cocaine, whatever the drug was. And almost always the animal would choose the drug-laced water over anything else that they had an option to. And almost always they would overdose and die. Now, they looked at this and they said, this is not how rats live. If we actually look at this animal, it's a social creature. And so they said, let's create its natural habitat. So they created something called Rat Park, and they put these animals in a very large cage where they were with a number of other animals. They had all kinds of stimulus. They had all kinds of ways they could build nests. They could socialize. They could have sex. They could raise their young. They had multiple food sources or things that they could engage with. And then they put the same drug-laced chemical in the cage. And what they saw was that the rats, they would use it on occasion, but they never used it to excess, and they never overdosed. And so then the question becomes, if we look at how people live, particularly here in New Mexico, how isolated they are, how little opportunity they have to engage in healthy social supports, to have gainful employment, to have meaning in their life, a reason to get out of bed in the morning. It's much more like the rats that are in an isolated cage. So then you say it's really not much of a choice in terms of when they're doing these destructive behaviors. So we need to be focused less on removing people from the drug or the problem, and more focused on building Rat Park, right? Making those resources available for people to make healthy choices.
Well, I'm going to try to do the leap from the Rat Park to the 100% Family Center. So when we start with an initiative like in San Miguel with Matt or with San Juan County, we've just started in Bernalillo County. 2 days ago, we literally, after 5 years, started in Santa Fe County. So you can go to our website and see where we are, but I want you to know that how we start the initiative is we are invited in and we survey families. Can you get to these services? And this will not surprise anyone in the room. 50% want behavioral health care and cannot easily get to it or get to it at all. And I could go down the list of all 10 of these services. 30% can't get there, 40%, 50%. So this is not news to you in the room, but the barriers are very interesting, right? Like, why can't they get to these services? And if you have a community forum, providers will say, well, I'm here, why aren't they getting to me? And it's really interesting to learn by asking families, asking parents, caregiving grandparents, what's the problem? And this won't surprise you. Cost. They don't qualify. They don't have transportation. The hours don't work for a mom who works full-time as a hotel maid with 2 kids, but the services are only available 8 to 5, right? She's not off work. Her work doesn't allow her to leave and go to an appointment. Unfriendly powers for working people is huge. They don't speak my language. And so there's a list. So again, we're a data-driven process. We are research. We are learning in each county, and every county is different, and each of these sectors. But when you finally get a report, and there is a Bernalillo report, by the way, you can look at what are the barriers to these services. And also we hear that as much as people want behavioral health care, that's not going to help them if they don't have a job. It's not going to help them if they can't feed their kids. So all these 10 services connect. And the problem has been historically that we're siloed. The people who provide these services in a county don't talk to each other all the time. So our coalition, working ideally with everybody who can make a difference in that county, is to get everyone in alignment. County government has programs. City government has programs. Health councils are promoting programs. Higher ed has programs, but they're not aligned. So and it's not all about money. In many ways, we don't need more money to solve ACEs and all the other problems, but we have to work differently and we have to work in partnership. And I'll end by saying that one thing parents have asked for is there just one place I could go to help me? Like, don't make Mona, who worked all day at the motel, now drive on Saturday to 10 places. Half of them won't be open, by the way. I mean, don't make her drive all over the county. Don't make her be on the phone for 2 hours. You've all had this experience. I'm a well-resourced guy, and trying to get medical care is almost impossible. What we have to do is make one place in every county. Put all the services in one place. And so we are proposing the 100% Family Center. And that would have everything on site. And if it can't be on site, we can also beam it in. We have something called the World Wide Web, and it offers most of these services or parts of these services. So we can have one place, you walk in the door, and it's as simple as this. It's not like, well, do you qualify? Can you be? Welcome. Welcome, Maria. Welcome in. What do you need? How can we help you? And then we have those services here. If we don't have them, we have a navigator who will sit with you in a cafe-like setting, not a clinical setting, not that there's anything wrong with clinics, but a friendly place where she feels comfortable and say, we're either going to get this service to you, and I mean these 10 services, it's on site, it's online, or our navigator is going to make sure that we get you there. So if we did this, this would be revolutionary. And not only will these 100% family centers get our most vulnerable people to services, it will be a base of operations for our initiative. So people will be building services within this entity, because we could build a 100% family center in one of our counties, but they wouldn't have a lot of services to refer people to. So we need people to be project developers and build the services. So the solution is right in front of us, right? We'll use technology, we'll use collaboration, and we'll get a county. And when we do our talks, and as you can imagine, I talk a lot, we say, think of your county as a country. How would your country take care of your people? Think about it as systems working together. So I think the good news is, and I'm not saying this is the only model, but I'm saying if you want to address the social determinants of health to reduce ACEs, we got to get these services in place. It's really as simple as that.
Thank you. And Dr. Stoffel, go ahead talk about some solutions, and we have maybe a couple minutes for questions.
So I can talk about it from a medical perspective and a multidisciplinary clinical perspective. One of the challenges, I think, is that there is funding available through Medicaid, but it's nearly impossible to navigate. There's a lot of bureaucratic barriers to that. I think a simple solution would be having people who understand how these things need to be set up, helping different programs set these mechanisms for reimbursement up. I think the other thing, elevating community voices, and so I think there are people all over the state coming up with these really creative solutions under a lot of adverse circumstances, but I think they need stable funding. I think there's just a push. I think we need to really elevate all of those different community voices too, and meet families where they are as well. I think that would go a long way in shifting the conversation on ACEs.
Thank you. So we have time for a couple questions.
Okay, well, anybody who knows me know I probably don't need a microphone, but hi, I'm Terry. Huh? I don't really need one. I'm Terry Grimborn with United Way of North Central New Mexico, and I work with partners, Albuquerque Public Schools, New Mexico PTA, and others on attendance and improving chronic absenteeism. And we know that all of this affects that directly. So my question to you all is, how do we get the legislature to understand that schools need more supports in this? Schools are that hub for communities, and yet they need support. They need more help to be that hub, to be those people who are getting those resources and bringing families in. So how do we do that?
Does anybody want to hit it?
So very good point. So these centers already exist in our communities, right? Schools, you just brought that up. And so then you start talking about community schools. That's in the book that Dominic wrote, right? And so how do you get 10 vital services accessible at a school? Well, we had the very first family center, if you will, in San Miguel County, a youth center. We were dreaming of a youth center when we first heard about 100% New Mexico in the book 100% Community. And so the idea is providing 10 vital services at the school. And yeah, so if you're having trouble with housing and you're a student and your family that's struggling with that, you're having trouble with food, right? Now we're working through our youth center that not just, many kids, all they eat is what they eat at school. And so not just breakfast and lunch, but dinner. We're doing dinner now, right? And how about what about on Saturdays and Sundays, right? And a lot of our rural schools are only Mondays through Thursdays. So what about Fridays, right? And so providing those. And so I think the idea there, one of the examples is school-based health centers. Now you've got medical and behavioral health care and dental care right at school, right? And so, those are those types of cross-sectional solutions where at school isn't just a place where you get education. It's a place where you get access to vital services and your social determinants of health are addressed. You could take that same, what other centers exist? Senior centers, in my communities, community libraries, there's church, halls, there's many different centers. And so it's about connecting so that at each one of those centers, and yes, using technology. Now we've got remote patient technology, monitoring technology for healthcare. So in the New Mexico hub and spoke model, even if you don't have a brick and mortar school-based health center and you're in a very rural place, Anton Chico, New Mexico, you can have an access point like Dominic was talking about where you can get a medical and a behavioral health telehealth visit. And then high touch, high tech, right? Where yes, there is that. And that really helps because now the kid didn't have to miss school, right? Mom didn't have to miss work to take the kid to the doctor's office. But I'm also the old-fashioned circuit rider for this program. Don't ride a horse, but I'll be making the tour, right, every other week and be hitting and being in person. And then the other thing in these schools is putting community health workers there. We heard about peer support. So everybody needs that support person. So by putting folks that, as we mentioned earlier, you don't speak my language. Now we'll put someone there that's a trusted member of the community. Give them a job. That's good for economics of rural places. And they understand you socially and linguistically better than even us primary care providers and physicians. And so that becomes another access point that reduces some of those barriers. So I think the solutions are there, but you're right. It's not a school problem, right? Yeah, truancy is not just a school problem.
Yeah, and I just would like, I love that you asked that question. And regarding lawmakers, because, we may have 8, 9, 10, $13 billion to spend this year. And I'll be very honest, until I started this program, working in it about 10 years ago, I didn't know who my elected officials were. I certainly didn't know who my state senators or representatives were. I certainly know who they are now. And when State Senator Bill Soules created our institute, and it happened fast. It was in a whirlwind, and I kept going, how does this process work? Like, how does a bill work? So if you have an idea, and as Matt said, schools can be these family centers. Schools can be the health centers. We have the infrastructure. 800 plus buildings already exist in New Mexico. Why not transform them, right? It's right, and the solutions are right in front of us, but it's going to take lawmakers, and I'll be short on this. I said to Senator Soules, I go, Bill, this whole process and a thing called junior money where people get buckets of money. Let me tell you, I was shocked at what's going on in am I allowed to say that on a panel like this? It's a beautiful experience of what's happening with democracy on the state level. I'm not going to talk about the feds, but on the state level. But I do want to say this. We don't need the president or U.S. Congress to come in and save New Mexico. We can do it ourselves, but to get to your lawmaker, there's a book. Because I said to Senator Soules, I go, you've got to write this out because these 24 steps to get a bill through and to get millions of dollars. He goes, okay, I'll write the book. So there is a book called, make a note of it, who said that? The Sausage Factory. And it's the perfect name for this book. And it will explain to you and everyone in this room what you need to do when you leave here. Get the Sausage Factory and you will be ready. And as you know, a lot of decisions are made now, not in the legislative session. But if you get the book, and I don't get a percentage of the book, but if you get the book, I'll get a PDF and send it to you. But I have to tell you, my eyes were like, you can't be serious, because he also tells the side stories of what's going on in the offices. I don't want to call them dark, smoky rooms, but I'll call them dark, smoky rooms. You You won't believe it, but you should believe it because, and by the way, Senator Souls is a huge advocate of public education and actually heads it's the Senate committee. I believe it's the Education Committee with the Senate. So he's the guy. So thank you for that question. And we all have to know our lawmakers. They all have to hear about this panel, what the AG wants to do. This has to become the thing, right? So there you go.
And if you want to make any comments of those, looks like we have another question. Okay.
Greetings, everybody. I'm really appreciating all the points that have been shared today. And Dom, to your point, by the way, my name is Valeria Alarcón, and I represent New Mexico's county and tribal health councils, which we're very delighted to be engaged with 100% communities. What has become very obvious to me, again, the solutions are right here in front of us because we do have statewide systems such as the Behavioral Health Collaborative, the Health and County and Tribal Health Councils, primary access coalitions, early child education, school-based clinics, and something that I have been engaging DOH in is together with the statewide coalitions to talk about where are the synergies in our work, where are these community health improvement priorities that are conducted statewide with DOH and 100% Communities has its very clear, framework and data assessments. And I think there's so much synergy with all the work that all of us are doing. And for me, I always think about systems, being systems oriented through collaboration in service of community members. And when we think about New Mexicans, our brothers and sisters throughout the state, 60% of them live in rural, frontier, border, and tribal communities, deeply underserved, incredible barriers, transportation, the list goes on. So it's all about access. It's all about equity, advancing equity, which is really access at the heart of it all. So I think there's an opportunity here, and I'll call out to Attorney General's office, if we can coordinate a convening much like this, but from a systems perspective, also including the voice of community members through their own lived experience to inform that very thing that we are all here seeking to create in service of. New Mexico has a surplus. New Mexico is not a poor state. New Mexico has every opportunity to make sure that every child, every person has everything they need to live a happy, healthy, and thriving life. And so I'm here to partner with you, Dom, with all of you in this room and beyond to make sure that that is a reality for every New Mexican in our beautiful state that we call the land of enchantment. Thank you so much.
Oh my God, that's great. Thank you so much. Beautiful.
So I think with that, well, thank you so much for thank you. No, yeah, we'll take a break now. And I left this up because just so that just to remember, we have a long way to go. We have to do this work, right? Otherwise, we won't change being in last place. So thank you. And so I think what I'd like, we'll just go down the line and we'll start on this end. Phil, introduce yourself, say a little bit about your work, and then if you would just, let's just get into it. What are from your perspective, those underlying dynamics?
Sure, thanks. My name is Phil Houston. I'm the executive director and founder of Lifehouse in Carlsbad, New Mexico. We provide a continuum of care for substance use and mental health services. And I appreciate being here today and this opportunity. I'll just tell you a story that happened yesterday that's pretty relevant. We run a detox. That's one of the services we run. And I get into the office at about 6:30, and there was a pregnant woman waiting in her car to come into detox. She'd been there since 4 a.m., and we couldn't let her in. And the reason we couldn't let her in isn't because we didn't have the staff, the nursing, the services available, but because the pharmacy regulation and law in the state of New Mexico doesn't allow us, because we don't have a 24-hour pharmacy in Carlsbad. There's no way for us to access medication. And because of the licensing, we're licensed as a nursing home. There's no licensing for detoxes. She had to sit and wait till 8 o'clock to come in. And so we have outdated licensing, outdated rules and regulations that don't match the crisis that we're in. And unfortunately, the systems, the bureaucracy isn't geared towards creativity and solutions, but geared towards kind of being locked and bound in these problems. And so I think on the one hand, that's one of the major problems that we face. On the other hand, another thing that happened yesterday is I had 300 people from the community in Carlsbad come together to raise over $300,000 for us to build more sober living homes. And the reality is that our communities are the places that need to be empowered. And you know, the solutions, the role of Santa Fe, the role of government needs to be empowering communities and providers to provide services, not creating obstacles and barriers. We need to err on the side of how do we help people get more care, not how do we make more rules to make sure that something doesn't get messed up. So I think those are a couple of things.
Hi, my name is Caroline Bonham. I'm a psychiatrist at the University of New Mexico, and then I also serve as the medical consultant for the Behavioral Health Services Division, and have had a lot of opportunities in that role with the state to work with a number of different agencies and programs around the state. I think one of the things that I'm seeing as a big barrier right now to getting programs off the ground is workforce. So there has been a lot of federal funding and a lot of attention around behavioral health recently, but it's interesting when we try to actually offer kind of like different funding initiatives to different programs, a lot of the answers we're getting is like, no, not right now. We don't have enough staffing to pull this off. And I'm hearing this we hear this across clinicians. We also know that since the pandemic, a lot of the state and county governments have also had a lot of turnover with workforce. I was just sharing my daughter's in law enforcement too, and law enforcement is also having a crisis in workforce. So I think that's something we need to be thinking about as we launch new initiatives. We want to make sure that the agencies have capacity to carry them off. But one of the ideas I'm intrigued about is this idea of like, we've been talking about how we function in silos, and how do we support training across silos too? So as an example, one of the programs that we have actually is, it's a telehealth-based program to support law enforcement officers who end up encountering people with behavioral health conditions. And then, so having a weekly kind of format where the law enforcement officers can then kind of connect with behavioral health clinicians and kind of train together about how to learn how to work together. And I think we don't do that enough across all of our training. How do we train nurses and, people from public health, people from psychology, psychiatry, nursing, together so they make these connections and then can support each other. So I'm thinking about interdisciplinary training opportunities as a way to kind of reduce some of these silos and also to help people kind of connect to their communities and help build our workforce.
Well, let me come back a little bit and let's connect it to how does your work connect to public safety? And then we'll come back around.
Well, all the time, in both directions, public safety coming to us coming to public safety. We talked about the underlying connections between mental health and ACEs and things to how that contributes to public safety. But really, one of the things we've really tried to focus on in our agency is that a lot of the places that we think in the public safety realm are the places where individuals with the challenges that we treat are first encountered. And historically, a person with a mental health issue comes to an emergency department or encounters law enforcement. That usually doesn't get them into treatment. It usually is an obstacle to getting them help, and maybe something that makes it harder in the long term even for them to get help. And we've tried really hard and had really good success building the partnerships with law enforcement, EMS, emergency departments, schools. These are the points of contact to being pathways to treatment rather than obstacles to treatment. And I think those partnerships are really important, but even when everybody has buy-in, what we're finding is undoing the systems is hard. Developing those pathways, even if everybody recognizes it and wants them to be there, making that something that the officer is trained and understands and happens smoothly, or the emergency room doctor buys into and is willing to do, that's a real challenge. And that's one of our main priorities in our agency is those intersections need to be pathways to help and not obstacles to it.
And again, a lot of the direct clinical work I do is directly related to public safety. I do assertive outreach with individuals with serious mental illness and substance use disorders who have difficulty engaging in traditional outpatient care. So we have an interdisciplinary team, and we go meet them where they are. And many of the people that we serve do end up having interactions with law enforcement. I was thinking though in the earlier panel too, there's these missed opportunities. So one of our programs actually provides case management for individuals. It's a wonderful program. It's founded by Bernalillo County. So people who are reentering from the jail system. And I think Bernalillo County is able to provide them with a housing voucher. We do the case management and we kind of, assess their needs about what they, about how to get into care. And this is actually a moment where people are so excited for change too. And so I often will sometimes I'll cover the intakes. And people will be coming out and they'll sort of say, oh my goodness, and they'll talk about their childhood and the adversity they had in childhood, but how, that they're really ready to make a change. And they really are excited about this new, opportunity. They're excited about housing. But they're worried about jobs, they're worried about kind of connecting with their family, they're worried about their children who are in the child welfare system, and they're trying to get into medical care. And what we're finding too is that there's these gaps. We've got the housing voucher, and then we're gonna try to work as best as we can for all these other gaps. But it is, we've got a wait list, I think, of 400 people trying to get into medical care right now. And so sometimes, it feels like this little, there's these moments where people are so ready for change, and sometimes we don't have enough resources to kind of say, hey, this is the pathway. So I'm looking at Dominic and this one-stop shop, and it'd be exciting to have more resources to offer to people at this moment. Another kind of moment where I see people ready for change too is when we work with women with substance use problems who are pregnant. And they're about to have a baby. And oh my goodness, that's a time that they are so excited and really wanting to make a difference, really wanting to change their life for their children. And that's another place. I know the Adobe program and other places kind of work with that. It's like, that's another place. Gosh, if we can surround them with resources, there's these critical junctures sometimes in people's lives where.
Right. And maybe that's why they show up at 4 in the morning. Dr. Lay, please introduce yourself and then talk a little bit about your work and the interplay with public safety.
Sure. I'm David Lay, a clinical psychologist. I got my PhD at UNM here 23 years ago. Since 2004, I've been executive director of New Mexico Solutions. We're a nonprofit community behavioral health service here in Albuquerque and Santa Fe. I'm also privileged to be the president of the New Mexico Behavioral Health Provider Association. One of the things that we are really seeing is that behavioral health has been grossly neglected in terms of support for infrastructure for decades. The funding for behavioral health is really kind of subsistence funding as we are, as a system, trying to move into new kinds of funding and data reporting strategies, outcomes-based kind of services, et cetera. What we're finding is that behavioral health providers just don't have the internal infrastructure to really be able to manage, report, track, and monitor these kinds of things. And a lot of that, in my opinion, goes back to what I regard as systemic bias against behavioral health. Behavioral health services are typically regarded as kind of not as real as primary care. Depression, substance use addiction, et cetera, they're oftentimes regarded as, well, that's just somebody being weak. But during the pandemic, I think all of us realized, wow, this is really hard. And a lot of people started reaching out for behavioral health services and then finding out there was a 6-month wait list, finding out they had to fight with their insurance company to get coverage, finding out there were no providers in their area that could work with them. And that is a direct result of the gross neglect that we have seen. We neglect our children and we neglect our behavioral health system that then can support those children that were neglected. So it is this awful internal spiral. And then we rely, unfortunately, on the public safety system to catch those folks. My agency, we've been working very closely with Albuquerque Police Department now for many years, helping them to revise their training, to make their training around behavioral health more person-centered, more focused on a destigmatized kind of approach to behavioral health issues. We're also at the same time providing counseling services to officers and their families. And what we are hearing and seeing is just a tremendous level of burnout in officers and public safety workers as they are dealing with banging their head against brick walls, trying to get people services who desperately need them. And unfortunately, we're seeing that same level of burnout in our staff as they are also now getting more funding and getting more support to provide services, and yet those services aren't there, and we don't have the workforce to support them. And as Phil said, we're dealing with 1960s level administrative systems that were calculated to restrict access to behavioral health because we didn't think behavioral health was really all that real or really all that necessary. I think that we need to start looking at behavioral health as a form of primary care. We need to lift the restrictions on access to behavioral health, and we need to empower behavioral health providers to identify, treat, diagnose, assess, and provide the treatment that's necessary without, I'm sorry, bureaucrats getting to decide what services are necessary or not. These are clinical services. I worked hard to get my PhD, and that clinical license lets me decide and assess what I think is clinically appropriate. But unfortunately, in our system, we have business folks at managed care organizations, and we have regulatory folks in Board of Pharmacy, as Phil said, that are deciding what's best for the system, for our neighbors, and for us. And I think those are some of the things that we can change to try to increase access to these very complicated services and systems.
Thank you, Dr. Lay. And Dr. Riley, if you please introduce yourself and similarly describe your work and describe the interplay between your work and public safety.
Well, good morning, everyone. My name is Melissa Riley, and I'm the director for New Mexico Highlands University's Facundo Valdez School of Social Works, Native American Social Work Studies Institute. And I am based here at the Albuquerque campus. And I've been in this position now for over 3 years, but I've spent a lot of time as a training and technical assistance provider for the Department of Justice Office for Victims of Crime, and doing a lot of training, on-site training, technical assistance, and working with tribes, Alaskan villages, and organizations that serve our urban Indian populations throughout the country. So I've been very privileged to kind of see various aspects of how behavioral health issues, substance abuse issues interface with law enforcement from both a city, state, tribal government area. So I'll have to put it in two different perspectives because I've also served as a superintendent of schools for a few years for one of our tribal communities in New Mexico. So one of the biggest issues that I see from law enforcement or public safety, criminal justice, and I'll just kind of portion this out, and what I do at the Institute as well, is we do have significant jurisdiction issues. In my time working with tribal court systems, with metro court systems, oftentimes when law enforcement comes into contact, they're the primary contact with someone who is believed to be under the influence or have committed a crime where substance abuse has, been part of the criminal interface there. And going up to the next level of adjudication, what do a lot of prosecutors do? They tend to whittle down the charges to where instead of focusing in on the various aspects of a criminal charge or charges, they may have a person who committed domestic violence, they were under the influence of alcohol or other substances, most likely they're gonna get just charged with the domestic violence or maybe even just the substance abuse. So there at the court levels, prosecutor levels, we often don't see the full realm of charges that individuals face when they come into our criminal justice systems. So definitely that is something that I see as problematic because there could be a whole trend of violence and drug-related violence occurring in our communities, both on and off the reservation, but we may not see that clearly written in any police reports or government records. And this is very critical because if we want to maybe say that we have a large problem with substance abuse, substance use in our communities, but we're kind of speculating because we're relying on behavioral health experts, but not really seeing a triangulated, data source through prosecution and sentencing or anything like that, we're kind of missing the mark. So I think as a part of these conversations, we do need to have prosecutors and other criminal justice folks here at the table to kind of hear about how we're being affected by even just the basics of prosecution. I also think that in our interface and what I do with my work at the Institute and as a consultant is that we do definitely have a lot of lack of multidisciplinary approaches that are missing from the work that we're doing. Often, I know here in the state of New Mexico, we may have 10 or more statewide groups that are working and they involve substance use, working with other agencies, including law enforcement. But when you think about like a community mapping approach, and what I've done at the Institute through our tribal social work is I'm developing and researching and developing curriculum and courses to address jurisdiction in tribal social work when we do work on the reservation and off the reservation. But I think that approach that I've been using is very relevant to our discussions here because we do have resource deserts in New Mexico. I live out at Cibola County where we don't have the same resources as another Pueblo community in the northern part of the state. So our responses and how we work with community members that are suffering from substance abuse or other mental health disorders is going to be very different. Training, the outcomes are going to be very different. And oftentimes, if you look at the data and the very limited data that's even come out with our juvenile justice reports, we're still continuing to have problems probably at an even greater level right now in responding or having resources and responding to repeat offenders. And we still have not gotten away from the children that are in foster care or they're now in the crossover phase. And unfortunately, being a tribal social worker, I am now dealing with children's children of who I dealt with over 20 years ago because we still haven't really addressed the crossover use problem that we have here in New Mexico. And this just doesn't here in New Mexico, it's around the country, so I really would like to say that New Mexico just isn't at the bottom of the barrel. It's just that we're using we're using linguistics to kind of frame how each state is positioned here in the country. And unfortunately, the words that we're using, what I say is linguistic avoidance, and I'll use this in an example because of the work I do with sexual assault is, when I worked with law enforcement, they'll say, well, your advocate said Jack raped Mary. But by the time we get into the actual police report, it reads Mary was an assault victim. So we changed the linguistics to kind of fit the work that we want or to kind of drive the outcome that we're looking for. And there's nothing that the community can see as that being a positive. What it does is it minimizes the level of work that we want to do as an officer, as an advocate, as a judge, or whoever we're working with. I mentioned a little while ago about my education, and then I'll be quiet here. But we're in a very critical part of our education with public education, with the Yazzie Martinez. And during my time as a superintendent or executive director of tribally controlled school and Head Start, we have a process, I think, that's being developed where we're going away from allowing communities to take control of the school and to work with schools to being a more blanketed, punitive approach to how we deal with students that are breaking rules and stuff within the school system. And when you look at, for example, our education data, our statewide education reports, including the Tribal Education Student Data Report, we see that we have more Native students and other minority students that are not graduating, they're truant, chronic absenteeism, and so forth. And that is a huge problem when you think about the laws here in New Mexico and how they're very imbalanced when you compare that with tribal codes. So if you think about a student who lives on a reservation that breaks a rule of the school and gets suspended or they get referred to a court system, the tribal jurisdiction, the codes are going to look very different than what the state code is. So where does the student fall in between that? And how does the community or how does the family respond to those situations, especially if alcohol and substance abuse is a problem? So I just wanted to share some of that and some of the work that I do in the curriculum development, and I'm really looking forward to our continued conversation.
Thank you. And I think we can just get right into some of the obstacles, and we're starting to hear some themes like jurisdictional challenges, legal frameworks, workforce challenges. We'll go down the line again. I want to elaborate on some of the challenges, the obstacles to providing effective behavioral health and mental health and substance use disorder treatment.
Sure. One of the challenges is the funding and the way the system works doesn't promote providers to be able to be resilient, to develop reserves. It doesn't allow us to develop capital. Like David mentioned earlier, it's subsistence. The only reason we've done a lot in Carlsbad and grown a lot, but it's because we've raised money in the community. Our profit margin last year was less than 1%. And as soon as we get something, we have to pay somebody more because we're trying to compete with inflation. But there's no indexing of behavioral health rates with inflation. Every 4 years we get some kind of increase that doesn't quite keep up. And so we're always trying to scrounge and we overwork our people and underpay them and burn them out. And we need a system that funds in a way that we can innovate. We can try new things. We can grow. We can be resilient and build reserves so that we have systems that can weather difficult situations. But the reality in the structure, the way we're paid, the way we're reimbursed, the way the system is, isn't to develop a behavioral health system that is resilient and innovative. It's one that just gets by and scrounges for everything they have.
So is your funding primarily from the state legislature, from the feds? Like, well, how does that work?
I think one of the problems that we have in the state is we get funding from all over the place, and it doesn't match up in how we report it or what we bill for. It doesn't have a coherent strategy. And so just with justice-involved things, we have, I think, 4 different justice-involved programs: drug court, probation, the RISE program in the jail. And each of them's different. Each of them has different reporting and application and requires different things. And they don't actually, even though they're all justice-involved programs, they don't work together or communicate at all. And that's just within our justice-involved programs, which is a tiny bit of what we do. You know, we have money that goes into behavioral health, but it comes through corrections or education, or it comes through the local county government versus the state government. And none of those places have a strategy that's coherent. And so we throw all these things at behavioral health and hope that they'll help, but the underlying system doesn't change and doesn't work together.
Well, what I'm hearing is sounds like there are multiple layers, administrative layers to administer.
Well, and then with
Quantify funding, what
the
the
little bit of money we have to pay extra people to navigate the administrative layers rather than actually providing services. You know, I'm not hiring a therapist right now because I have to hire a person just to deal with credentialing with insurance companies and Medicaid, because the monthly burden to have 20 clinicians that each one has to be updated and checked. And if you miss that for one day, it takes 90 days or 180 days to get it fixed. And in the meantime, you either can't have that person provide services, which means the community doesn't get them, or you don't get paid for those services just because of silly, superfluous administrative things. And that drains our time and our energy and keeps us from helping patients.
It's interesting, both David and Phil have talked about this phenomena where behavioral health is really regulated compared to physical health care. And I think behavioral health is an interesting thing. We all need it, but all of us have behavioral health symptoms in a different way than we have physical health care. So when we go back to the 60s, there was this real excitement about building this community mental health centers that were going to provide everything for everybody and kind of be these one-stop shops. And I think we're here again thinking that's what we need. But what happened in the 60s, right, is they didn't have any regulations. They sort of poured this money. And what happened is actually the most well people came in because we all could do with a little bit of behavioral health support. I often say, like, I could do with case management. I could do with therapy. I could deal with all of this. But I may not be the one that everybody wants to prioritize. So what happened in the 60s is that sort of the most well people were able to get to that first place in line, and they saturated the resources. So it's a different phenomena than physical health care. I always sort of joke, we don't go for extra kidney dialysis if we don't need it, or we don't kind of have a little bit extra. But we could all use a little bit more behavioral health. And so I think this is always the challenge for a state and community. How do we find that fine line of not regulating too much, but also making sure we're not regulating so much that, so we're protecting the resources for the people who need it the most, and also making sure we're not creating barriers to access.
That resonates with something we heard in the first panel of how do we support get the bottom 25% up, right? And it seems like that's probably the population and bottom is probably inarticulate, but
The most vulnerable,
the most vulnerable folks, it's probably the population we're trying to get the services to.
Yeah, one of the things that we wrestle with here in Albuquerque in particular is folks with very severe mental health issues that are resistant to accessing care. And I say this absolutely not to stigmatize these folks. It is a very sophisticated, nuanced process to engage them in services. What we see in Albuquerque and New Mexico is a high number of folks that have very severe mental health issues, engage in criminal behavior, are then identified as not competent, walk out on the street, and are resistant to accessing care to manage those issues. And it becomes this revolving door. And unfortunately, it contributes to the stigma against behavioral health because people, and unfortunately, we're hearing and seeing this in the news. I mean, in Lewiston, in Maine, the individual with history of mental health issues and access to guns and resistant to accessing treatment. The New Mexico Supreme Court right now has a committee and a panel working on potential revisions to the competency standards or rules in New Mexico, trying to wrestle with this issue. And just as Dr. Bonham said, we have a system that unfortunately does not prioritize or incentivize services to those folks where we can achieve some of the most significant community impact. In a fee-for-service environment, behavioral health providers are paid for providing an hour of service, regardless of to whom. And so providers choose to provide services to the folks that are easiest to serve, that are not going to be calling in bomb threats or, attempting to assault staff and stuff like that, even though those folks are the ones that most need the service. Again, our system has just turned things on its head and incentivized services that feed a business environment to a degree in a subsistence environment, but don't serve community needs. And that, again, I think is the thing that we need to start looking at. We need a behavioral health strategy statewide that identifies who are the folks that our state most needs services for, and how do we change the system to incentivize that. That's the question that, I think that we now need to start wrestling with as we realize behavioral health is really important. It's really important for our personal well-being, for our social well-being. And what do we need to do now to build this? As Dr. Bonham said, again, the 1960s strategy just didn't work. So welcome to 2023. What do we got?
Thank you, Dr. Riley.
So that, for me, and just the work that I do and the research, and I say this with all love and respect here, but we still, there are several things that are affecting our community members from accessing services. There's still a stigma about what behavioral health is, what substance abuse is. We haven't clearly defined that or have been able to really having prevention-based messaging. That is one big problem. Challenges, a lot of folks say, well, you're in a rural community, you're in a tribal community, we've got telehealth. We still don't have good internet access within our tribal community. So how were we supposed to do that? My mother, who is 69 years old, just got her first phone and has to call into Albuquerque to get her services. So now she's got a phone, but she lives up against a large mountain where she doesn't get good service. So, so there's a lot of challenges to what we're doing. But another thing, another added layer of this is that we still don't want to think about opportunities for being innovative here in the state of New Mexico. And what I mean by that is that looking at the possible unusual resources in our communities, in our rural communities, as being service providers and being eclectic. And what I mean by that is that we do have community health workers, we have community health representatives, promotoras, we have advocates, we have a whole number of folks that we rely on for specific services. But when you look at other models, like even the state of Alaska, I had a meeting last week in Atlanta, and we had 4 folks from from Alaska there. They're not only using their dental aids as a part of their behavioral health services, they're now recruiting elders from their elderly centers to come in and work with individuals when there is no provider available. So there's no one to fill the gap here, because we have it kind of fixed in our mind that only a PhD or a licensed in social work person can go and service this individual, as opposed to thinking about opportunities of cross-training or alternative licensure or grandfathering certain folks. That's something we did in the early 2000s. We grandfathered KDAX, which was under the old Indian Health Service system, into LADAX. And, I mean, there's just so many opportunities. We have a gap, and it's like this false expectation that we're gonna build this miraculous workforce, and we're gonna get paid, and the legislature's gonna fund us, and we're gonna do all these great things. And that could take 10 years from now. It may not even happen in our lifetime. But there's things that I think we can do to offset this or minimize the demands of this in our community. These services, they're essential, but I do think that we need to work extra hard at really minimizing that stigma of what behavioral health is. I think we're used to doing diagnosis and, you know, somebody's got a problem, we're gonna give you Xanax, we're gonna do all this stuff. Well, now we're perpetuating another problem because we have people that use substances, prescription drugs to mask other problems.
If I can just add on to Dr. Riley, I mean, we heard in the earlier panel about, the importance of psychosocial determinants of health. Well, I enjoy having a PhD. I love getting called Dr. Lay when they call me to the table at the restaurant. That's about the only privilege I get. But it doesn't take a PhD to work with people around psychosocial determinants of health. And it is only in the past couple of years, literally only in the past couple of years, that we've been able to start changing regulations to allow, for instance, paramedics and EMTs to work as behavioral health providers in certain settings. My crisis triage center in Santa Fe, we just got, and with the help of Dr. Bonham, to be clear, we just got regs changed that allow us to hire paramedics in there on the mobile crisis team, rather than requiring it to be a licensed therapist that goes out and tries to help people in crisis. It was only just a couple of years ago that BHSD changed some of the rules to allow community health workers to be providing billable behavioral health services. As Dr. Riley said, in resource-poor deserts of behavioral health services, we need to start looking into those communities and identifying some of those resources that do exist, but might not have some of that traditional education or that traditional license. Now, I can support those behavioral health providers that are in the urban areas. Now with telehealth and stuff like that, we can provide really rich levels of support and supervision to those folks in the community to most effectively work with those folks around the determinants of mental health, psychosocial determinants of health. Without getting buried in some of the nuances or complexities of behavioral health. But that's the creative thinking that I think Dr. Riley is putting forth. Looking again at what we need and how do we get there, rather than what do these 1960s rules and stigmatized view of behavioral health limit us to.
It sounds like we're starting to get at solutions, and it seems like we're talking about what are the frameworks that can unleash the creativity to hit the needs of the community right now. So let's keep going with the conversation about these solutions, because we want to leave time for a couple of questions.
Well, one thing I'll add to what the last two just said is peer support workers. We have 100 employees at Lifehouse, and 14 of them are certified peer support workers. And they're the thing that our agency centers on the most, because they're the ones that honestly most of the time can make the most impact. And they don't have a PhD, they have experience and a little bit of extra training and some supervision and support. And I think we need to, one, expand what peers can do. There's some simple things that they could do that we don't allow them to do. We need to pay a wage, billing rates for peers where they can make a career out of it and not treat them like they're second-class providers comparatively. And right now we have a freeze on training them, and I have people waiting to be trained to be peer support workers, and it's a great solution. It's something we can create 6 years faster than a social worker, but the system is resistant to it. And honestly, for most of my clients in rehab or in detox, the peer support worker is going to make a bigger impact than the therapist that they see. And we need all the pieces, but there's some solutions that don't require PhDs and massive workforce changes just from the people that we have, and we have to use those resources and make our systems adapt and adapt quickly to doing that.
Dr. Bonham, did you want to?
So again, I think that idea of interdisciplinary training too, because I think we need to be working as teams across disciplines, so that we all kind of can know what each other's strengths are and how to sort of support things. I think we don't do a wonderful job in terms of working in healthcare teams and training into healthcare teams. The other one, we had a pilot program around forensic navigation too. So as we think about this intersection between the public safety system and behavioral health system too, so the forensic navigators, they have this model in other states. So you catch people at these sort of key points. So either when they have been, they've been found to be incompetent and their charge is about to get dropped. And so you can kind of connect them in a warm handoff with a forensic navigator saying, hey, you're doing well, but you're staying in the community, let's connect you to treatment. You can also do this like as pre-diversion. So actually, and again, these forensic navigators can be peers with lived experience, community health workers too. And so thinking about a forensic navigator model.
We have a few minutes to go to questions.
Thank you. I think my question is for Dr. David Ley, maybe, and also Philip. Just recently, I think that the governor has now renewed her executive health order, just even maybe yesterday. One of the things that is really concerning me as someone in this space is the mandate within 24 hours to get care, and then 7 days. And really, what my understanding is, and I just want to say this, and then I'd really like to hear you respond, is how are you feeling? And from where I sit, I feel like this is adding to more of a crisis when we're mandating this without a plan or a place to get there, to say that we're going to have this. I send out a monthly newsletter that talks about, we have everything you just said. The state is sitting on 20 million for behavioral health. The county is sitting on 91 million. So just mandate, is that creating more of a crisis right now than what you would like to see? And how do we fix that? Or what would you like to see, especially from lawmakers, from the AG? How do we step back instead of just mandate things that are going to make it even worse?
I will say Governor Lujan Grisham has been a support of behavioral health for years. I worked with her when she was at Department of Health during the 2012 behavioral health audit that shut down providers in New Mexico. Governor Lujan Grisham in the House of Representatives at the time was one of the only federal legislators that was really raising concerns. I think her intent is very positive. I think that these are aspirational goals. I am, of course, very concerned about an unfunded mandate, and I don't know how on earth you could enforce that, because if you tried to enforce these rules, you're essentially going to put out of business the limited behavioral health providers that we have. So we're all kind of confused. I would also say that I don't know that any behavioral health providers were involved in a discussion around trying to set those goals. And if we had been, I think it might have been a different conversation. We might have ended up with something different. But it's bringing attention to a critical issue, and I'm in favor of that.
Yeah, I think coming from a rural area, we face an even greater challenge. So recent workforce report came out. In Eddy County, I have 1/5 per capita the number of behavioral health professionals that they have in Albuquerque. Currently, I've increased our capacity in the last year and a half by about 50% for outpatient counseling, and I have a 400-person waiting list. And we're the primary provider of behavioral health in Eddy County. I mean, there's a few other counselors and things, but I want everybody to get in the day they call us, and I do everything I can to make that happen. But the reality is that I have people on my waiting list from 2 years ago. Between getting a provider for them and then getting back a hold of them and seeing what's devolved since we got a hold of them, since they applied for services. And so, like David said, we should have these goals. We want everybody to get in immediately, but there's a disconnect between reality and what is in that proposal, I'll say. But we're trying. But it certainly wouldn't help us to get punished for not seeing people faster.
One last question.
My name is David Burke. I'm director at Serenity Mesa Youth Recovery Center here in Albuquerque and board president for NAMI Albuquerque. I really agree with what you were saying, Philip, about they make it really difficult to spend money. And what I mean by that is we try to provide services, and some of the contracts that are in place are like, wow, you have to hire a full-time accountant. You have to hire, your clinical director spending 20, 30 hours a week trying to figure out all of the ins and outs of the contracts. And some of the questions are just not beneficial for people who are in recovery or people who are suffering from mental health. Did you fix them? And how long have they been fixed? It's basically kind of the general questions that they want to fix. And I don't know that you can do that in substance abuse and mental health. And I don't think it's a fair question. So I think there's got to be a way that we can come together to figure out an easier way to spend money, to hold facilities accountable for how they spend the funds, making sure that they're spending it on the things that they're spending, but make it somewhat easier so you can provide more services to the people that you want to provide services to. The other thing I'll say is the state has a lot of money this year. We shouldn't have any excuses as to being able to have the funding to do something different. And maybe a question for the Attorney General, if we won that lawsuit for the opioid money, how are we going to hold people accountable to make sure that that money that was actually got off the deaths of a lot of New Mexicans is being put and spent and not reallocated and put to different areas that it shouldn't be going to?
Yeah, I love that they give money to mobile crisis, but tell Phil he can't buy a car with it. So be mobile, but I guess on foot.
With that, I think we'll wrap up. But what we're hearing is this theme of, and we heard in the first one too, illogical requirements for trying to get the work done.
Can I say one thing real quick? With that question, do we have a bigger problem in this state with behavioral health and substance use, or with behavioral health agencies misusing funds? We put so much effort and energy into making sure the funds don't get misused, and we miss out on how many more people we could help. And I'm not saying we should get rid of accountability, but I think we have to weigh what's our bigger problem and what are we going to put our energy into more.
Amen.
Thank you all.
Thank you. Thanks for the opportunity.
So I want to thank everyone for engaging in a really insightful conversation in the first two panels. And I'd like to try, and I think, Dominic, I'm gonna direct this at you. I want to try and cover as much ground as I can. And so I'm gonna do something a little different than what we did with the law enforcement panel, but I really want to engage in a pretty robust dialogue on systemic failures, and then also, but pressing each of you from your perspective and your engagement and understanding of these systems to give us concrete and specific examples about how to fix it. Because I think one of the most insightful things that I heard is that we have to engage in this work at the level of the individual, at the level of a family and a household, at the level of a community, and at a system-wide level. And I think a lot of times, what I have come away with is that we have individuals who want to engage in this work but don't quite know how. We have family members and others who are concerned about their friends and neighbors, but they don't quite know what to do. Seems like at the community level, we have some really thoughtful and engaged folks doing incredible work that often goes unnoticed and unreported. And it's at the state level and at the systemic level that I have a keen interest, obviously given my position as Attorney General, but also in terms of trying to solve some of these issues. And I want to start off by inviting each of you to sort of reflect on some of the things that you heard in the first two panels. And specifically, I took a number of notes, and it was interesting to me the parallel that I heard from behavioral health specialists and people who are working on a public health approach to solving our public safety issues. the parallel that you hear between what you are saying and what law enforcement is saying. The application of rules that don't make a lot of sense to people on the front lines. The burden of administration, the burnout of people who are on, who are at the sort of tip of the spear in terms of trying to solve some of these challenges. The challenge that we have in recruiting people into this space. And making sure that we provide an avenue for everyone to contribute to it. But from my perspective, I think addressing early childhood trauma, intergenerational trauma, and a continuum of care that focuses on infants, people who need support at the very outset, but all the way through their development trajectory. There has to be a way to intervene in a thoughtful way so that we can make the kinds of investments. And the other thing that I'd like to sort of frame for the conversation at the outset is that I think it's important for all of us to recognize that we're in this really unique moment in the history of our state. We have a fundamental recognition that this is a necessary step that must be taken. And we also have the resources available to us. That hasn't always been true. But once again, we are coming into a budgetary cycle where we're expected to have record surpluses. And so one of the things that I think we all should go into this session recognizing is that lack of resources and lack of funding should not be an excuse for not being able to pull these programs together. But it seems to me, and this is where I'd like to kick off the conversation. One of the things that people talk to me about all the time is they ask me, what's wrong with the criminal justice system? And I usually try by telling them first and foremost that you shouldn't call it a system. You have a bunch of people working in proximity to one another, engaged in various pieces of the puzzle, but it's not a system. A system implies coherent strategy, a shared vision, integrated resources, commonly shared objectives. And what we end up having are people working in silos next to each other. And I am, in listening to all the things that were discussed this morning, it seems to me that there is a certain relevance to the work that you do and a misconception that it is a system. It doesn't sound to me like a system. And I guess the question, the opening question, and I'll ask you, if you haven't been on a panel yet, to introduce yourself and talk a little bit about your role in the system. But talk about that. Talk about how a lack of a coordinated strategy impacts your ability to do things on a day-to-day basis and identify and help the people that I think we all recognize need help, not only for their own sake, but for the benefit of all of us who wish to live in a healthy, safe, and peaceful community. So, Director Baucus, I'll start with you.
Sure. Good morning, everybody. My name is Nick Baucus. I am the Director over at Human Services Department for the Behavioral Health Services Division. I also serve as the CEO of the Behavioral Health Collaborative. And first, I just want to thank the Attorney General for putting this together, because these are the types of conversations that we need to have. It's not helpful for us to kind of sit there and think of what do we need to do to make it better. We need to have the conversation to understand that. So I appreciate this opportunity. Similar to you, I do get the same question of, what do we got to do to fix behavioral health? And I look at it as a jigsaw puzzle. We have to have many pieces because there's many parts to this. And what I heard today, repeated over and over again, even if we didn't use that exact word, but I believe Dr. Riley used it a few times, is stigma. And there's two significant stigmas here. The first is removing the stigma for people to feel like they can't access help. Now, whether or not there's the ability to get help in their community, we can certainly work on that and improving that. But to have people feel that they can go and get that help is the first big hurdle. The second big hurdle is we have to remove the stigma of what behavioral health is. And what I mean by that is, for many years, and Dr. Lay kind of referred to this, but, you know, for many years, we had what was called the X waiver. If you wanted to get treatment for substance uses, that physician had to have what was called an X waiver, and you had to go through many hours of training. We never did that for a physician to get insulin, which, if not done right, is just as dangerous a drug. And some would probably argue even more dangerous. We never did that with antibiotics. We never did that with many other areas. Okay? But for opioids, we put this in place. Okay? We need to start looking at why do we have these hurdles that are preventing, instead of doing 8 hours of training for an X waiver, which I'm happy to say that earlier this year that was lifted, okay, by the federal government. But what other areas are we preventing our providers from doing what we are calling them, which is providing? So we really need to look at that. And I think the other part, and I don't want to take up too much time because I think Dominic has 4 hours worth of stuff, but
It's gonna be long.
But I'll just say this, is that we really need to be looking at our prevention efforts, which was mentioned on the earlier panel, and which is what the basis of ACEs is, okay? When people always say, what's the magic wand, the magic lamp, whatever that might be, my answer is, sadly, we don't have one, because this is something that we need to work on to break that generational issue. And that's going to take time. But it all starts with those multitudes of steps that we have to take to get us there. And the first thing is prevention works hand in hand with treatment. It works hand in hand with recovery. It works hand in hand with taking care of crisis. That's the jigsaw puzzle that I'm talking about. It's the multitude of pieces all communicating. And it's going to take folks to start thinking a little bit more, what can we do outside of the box? What are some of the innovative things that are going to work for us as New Mexicans, whether we're in Albuquerque or Santa Fe or a rural area like Las Vegas or Clayton or one of our tribal communities? So those opportunities have to have an equitable approach, recognizing that those needs are going to be different from community to community.
Matt, from your perspective, and one of the things that we really tried to do in bringing together the panels that we have this morning is to bring a rural perspective. What are some of the unique challenges for someone operating in rural New Mexico that policymakers really need to be cognizant of when they're putting together a strategy that focuses on all communities? Because it isn't the same. My dad grew up in a very small town in southern New Mexico, and getting to the front door and having the conversation is just different in those places. And I really would like to touch on, I know Dr. Riley mentioned it, but, you know, Phil and others mentioned it. Dr. Lay talked about the importance of allowing people who aren't clinicians, that haven't gone through all of this extensive training, but they can engage in peer support work and they can speak to community members. How do we open that up in rural New Mexico to make services available and start building communities that help developing a network for people that they can rely on?
Yeah, I think, so I think the first thing, Raul, that comes to mind is, you know, I'm a land grant there. And the land grant, not that I am an heir to, but the land grant that I live closest to, San Miguel del Vado, you were on there yesterday, but wearing your ranch suit, protecting the Pecos River and making sure we still have access to our land, not in that suit,
yeah,
right?
My staff was laughing at me. I don't think they'd ever seen me dressed. They thought I was going to show up at the river wearing my suit.
So that'll get you in the door better wearing that suit over there than the one you're wearing right now. You know that. But, you know, I think understanding it's about relationships. when it comes down to it, it's just about relationships. Relationships mean everything. Nick and I battled side by side for 3 years against a pandemic in Northeast New Mexico. And the relationship that we founded, blood, sweat, and tears, at all hours of the night, makes for the solid relationship that we have now. And that's that same, relationship there. I think, I'm just a simple guy back to the river, okay? So it's a river. Yeah, I describe, both gentlemen to my left and right have heard me describe this many times. Up in the beautiful streams, think of the Pecos, right? And in our beautiful mountains of northern New Mexico, that primary prevention, yes, it's a much more tranquil place. And so again, what kinds of solutions do we have there? What kind of needs there? Back to the youth center and that idea of primary prevention. I think of Grace Gallegos and our GRACE program that we have in San Miguel County, which is, I founded Semillas de Salud, growing our own health professionals and using common ground for early on interventions with greenhouses and the work that we do there, not only to teach STEM, but to, put the value and connect a generational gap between our grandparents and our grandkids, and teach taste buds to like tomatoes that grow fresh off the vine, not, the cardboard ones you get from Walmart. There's those types of things, meeting people where they are, to say that, yes, we're underserved, but we're so innovative. So it's not like we need a handout. What you need to do, and I hear this all over the country now, I serve Secretary Becerra on his National Advisory Committee for Rural Health and Human Services. So my first two meetings, Bend, Oregon, and Hugo, Colorado. And in both places, I hear the same thing. Old cowboy docs, what I aspire to be, saying, stop trying to, say, here's the policy, and in rural, figure out how you could fit within this payment structure or within this policy. Instead, we know what we're doing in rural. Pay us for what we do. And by the way, if you don't, we'll do it anyway. You can tell us what you'll pay for, and what we can maybe even do regulation-wise, but you can't tell us what we can do, because we'll do it for free. If it's regulatory, maybe we won't even chart it, but we'll still do it. And so, those old rebels, right, that are saying, have these systems that fit what we do, because we're innovative, we're smart, we're not, country bumpkins that aren't smart enough, that don't know, we are super smart, we are super innovative. And so I think that's the way back to valuing people where they're at. And back to Grace Gallegos, there we're talking about a 19-year-old that died of a fentanyl overdose. She was on nobody's radar of being at risk. And she didn't want to be a Semilla de Salud. She didn't want to be a grow your own healthcare professional, but she did want to be a law enforcement. And unfortunately, she died before she went off. She was going to go and serve our country first, and then come back and follow Sheriff Lopez into law enforcement. But she died first. And so, using those grow your own health professional, grow your own sheriffs, grow your own first responders, and then they'll stay home, right? And then they'll be able to connect with people culturally, linguistically. That's really what we need in rural, instead of exporting our most valuable resource, our educated youth. So just the last thing, Taylor, it's a semillas de everything, right? Semillas de políticos, semillas de law. So my son Isaac, last year when we were fighting for the opioid settlement, to fund the residential treatment center, all the way from a youth center to the downstream residential treatment center, to use the opioid settlement funding to fund that in San Miguel County. We were scrambling to be there as expert witnesses, and so I was driving in a scramble with my son, and that was trying to go visit a college, and on with Taylor, and he said, well, what's he want to do anyway? And I said, speaking of which, law. And so anyway, I was on speakerphone, and Taylor got to give my son Isaac a few little tidbits. And I was telling Taylor when I got here earlier how it really was impactful as a youth mentor, and has, it's kind of, he had to find his own way. He wasn't listening to Dad, but helped him find his direction. And so, I think it's that, don't feel sorry for us in rural. Yes, we need help because we don't have enough resources, but be like, we need to help you because, wow, you're so amazing, the things you guys come up with. Yeah, so it's kind of back to that local control. And meet us where we're at, which might be around the table with a cup of coffee or at the ranch or at the river.
Well, one of the things that I know was up on the 10 vital services that was included, that was part of Dominic's favorite slide, was youth mentoring. And we got a question about chronic absenteeism and truancy. I think the latest statistics were something like 39% of children in New Mexico were chronically absent. And in thinking about the importance of one of the most exciting ideas, which I hadn't heard of before today, was establishing these 100% family support centers.
Wow.
And logically, I started thinking, well, where would we do this, right? Are these places we're gonna have to build? And then fortunately, we had a conversation of, no, you got 800 schools in every community, and especially in rural New Mexico. My dad's from Hondo, New Mexico. My wife's family's from Mora. Anything in those communities, wherever they go, they're gonna have a community event. Do you know where they go? They go to the school. So the question I have right off the bat is, why aren't these utilized right now? Maybe not 24 hours a day, but extended after hours throughout the summer, and make them centers that involve not just educating kids from 8 to 3, but supporting families from 8 to 8, 6 days a week. That seems to me like a logical place to start reconnecting community, to start training people and delivering resources. I'm sure you've had that conversation in Santa Fe, Dominic. Tell me why we haven't seen more of that.
Well, when I was invited to this panel, I thought, God, what will my angle be in terms of what will the AG, what would he like to hear? What would this office like to hear? And what would the 50 people want to hear? And because we could all talk about 1,000 things, but I'd like to bring it back to a really, really difficult and fundamental question, and this will get at your question, which is why haven't we done this? I mean, it's so clear. We have the buildings, we have staff, we have the models, we have the research, we have the data, and we sure have the problems. But the solution is sitting.
And we also have the money now.
And we have the money. We have the solution sitting right in front of us. It's not like, how could we solve this? This is impossible. The infrastructure is here. But this is the question that has to be answered. And my co-director is Dr. Catherine Ortega-Courtney. Her PhD is in experimental psychology. So you can imagine our conversations we have every Monday morning on our Zoom call. But we invented a course. This is available to all of you. And the title of the course upset some people. And the title of our course, which outlines all the work we're doing, is A Child's Right to Survive and Thrive. Because we're talking about services for surviving and thriving, but do children in New Mexico have a right to survive and thrive? Do they? Is there a law I guess I'm sitting at the right table here. It's more than law. It's ethical. It's moral. It is legal. But I think that we have to, those of us in our room, and I think this is a soul-searching question. Do our children deserve services for surviving and thriving? Not PR, not slick websites, not political slogans. Because if the answer is yes, then we have solutions right here. We're going to start converting our schools and community centers and youth centers, and we could start this project tomorrow, even without money. It's working differently. Up in 100% San Juan, which followed the lead down in San Miguel, looking at what do we already have, what can we build on, they went to Presbyterian Medical Services and said, well, here's this idea for a family center. And they said, well, we already have a building that does half of those. Why don't we just extend it? So it's a matter of, It's fundamentally a matter of our ethics and our morals if we believe that our children and our students and our families deserve these services. But if we get a yes from our leaders at the very top, then this will happen. And if we don't get a yes, then we need new leaders. It's really as simple as that. It's time to do it, not to have excuses. And yes, we have the money. But even without the money, if we work differently, communities come together and make these things happen. We're just blessed to have resources where we could start this today. And we could have a family center up in all 33 counties coordinating the other annexes being developed at schools and libraries. So I guess I want to say that what's important in this work, you have to have visionary leaders. If you don't have a vision, as the Attorney General just said, we have all these schools. That's a vision. Like, why can't they be this? But if you can't see it, it can't happen. So I'm not gonna do a 4-hour keynote as much as I'd really like to, but I think that's fundamentally, the good news is this: we know the problem, we know the solution, we need visionary political will. And it's really as simple as that.
Thank you. We are joined by a couple of new panelists who haven't had an opportunity to address the group this morning. And I want to start with Ms. Willie Mae Smith. Talk to us a little bit about the RISE program in Lincoln County, and specifically, what are some of the challenges that the kids in the juvenile system in Lincoln County are dealing with, and what kind of work we can engage in to frankly get them out of the criminal justice system and into a more productive and a healthier space.
Good morning, everyone. My name is Willie Mae Smith. I am the program manager for the RISE program, which is a reentry program. We are housed at Lincoln County Detention Center. It's an adult facility. I'm also a licensed therapist, and so I'm kind of the puppet master of the RISE program. Well, some of the program here, what we do is that we actually, our basic program is, I always say I have a captive audience, but anyway, we do educational and also therapeutic services while an individual is detained. And some of the groups that we do are individual and group therapy focused on substance use. We also, the other parts of our program is that we offer MRT. Some of you know about MRT and moral recognition therapy. We do mindfulness, meditation, coping skills for anger and stress. Also, for a part of my job, I do a lot of referrals for treatment and outpatient treatment. I also do assessments. We have AccuDetox. We have wellness, physical, and cultural appreciation in the detention center. One of the beauty. Okay, I'm sorry. I'm sorry. Okay. And one of the things, one of the things that we do, I really, I like to say this, is that, you don't have to have a lot of money to do a reentry program. You have to find partners in the community that are willing to share the vision with you. For an example, we partnership with Eastern New Mexico University at Ruidoso, and they have a lot of money that they help us with, not with money, but they buy materials for us. We have a 100-hour reentry program, and they provide all of the materials free of charge to us. And that's one of the conditions of being in the RISE program, that you do this. Is a series of 10 books which covers anger management, coping skills, and other different areas. Another part of what ENMUR does for us is that we offer GED classes, and not only that, but construction trade certificate. So far, we have had 2 people that have completed their certificate and have been released, and they're doing, I guess, construction. But it's been a really nice partnership between the Lincoln County Detention Center and ENMUR. as another piece of that, I'd like to interject is that, you know, there are other communities, there are other community providers that are willing to link with us and help us. And so you just have to find kind of like the needle in the haystack, so to speak. And so those are some of the things that we do. As far as the challenges of doing a reentry program in a detention center is that most detention centers they don't have an educational component that is built in, for example, rooms. So we have to share a room with the court. And whenever court is finished for the day, around about 2 or 3, then that's when we do all of our educational programming, is when they're finished with court. So that's one of the challenges. Number 2 is a lot of the, while my coworkers, they're not really mental health providers, but they're willing to learn. So one of the basic things that we taught, or that we had training for, is trauma-informed care. Because we get a lot of individuals that are detainees who have a lot of trauma and they don't know what to do with it. And so we do a lot of that trauma-informed care at the detention center. The work, it's fun, really, believe it or not. I'm having a lot of fun. I've been working for the RISE program for almost 3 years. And one of the significant changes, because I had group yesterday before I drove here to Albuquerque, and I told one of the groups there, I think I had 3 groups yesterday, and I told them that I was going to do a presentation today on the RISE program, and they gave me their opinions, and they were saying, Ms. Smith, he said, there was one individual that was there when we first started the program, and he said the jail was bad, and the morale was low, and people were banging on the doors and just really, I guess, experiencing trauma again, I guess. But anyway, he said, then he's back again, but he told me, he said, but this time, the RISE program has significantly changed the atmosphere of the detention center. There are some people, believe it or not, there are some people, detainees who want to stay in jail so they can continue receiving services. And I'm baffled, because it's amazing how some of these people get involved with some of these classes and groups. And a lot of people loved AccuDetox. They like to it's a stress reliever, and they love to do those kinds of things. Physical activity, a lot of you know about being physical, is that, increases the dopamine, and they're feeling good. And so it's kind of what do I say, a mixed feeling kind of a place, where some people really want to be there in detention, and they don't want to leave, whereas others, when they first get there, they're just pacing the floor like, lions at the zoo. But once they get involved with the program, then they're calm and they're focused and they're working on things. And so those are some of the things that we do at the detention center. And the bottom line is that I'm looking at other areas. I'm always planning ahead of time. And what I'd like to see happen is that I'd like to do a wraparound approach where we have a provider on the outside, where people, when they walk out of detention, there's no RISE program, but I want to connect people with a RISE program outside of the detention so they can continue to receive services outside of the detention.
Thank you, Willie Mae. We're also joined today by Joe Andazola from the Grant County Detention Center. Can you talk to us a little bit about, what you see are the primary challenges to providing services, and specifically substance abuse treatment services for people in detention, and what we can do to more effectively deliver services so we can lower recidivism rates and improve the chances, frankly, that the individuals that are in detention aren't going to come back again and again.
Good afternoon. My name is Joe Andazola. I'm the warden of the Grant County Detention Center. I've been doing detention and corrections for over 20 years. Throughout the years, I've seen many changes, but I do see that the mental health issues and also the substance abuse issues are ever increasing. And also because of all the issues and problems we've talked about today, 9 times out of 10, if you have a substance abuse issue or if you have a mental health issue, where do you end up? In jail. Jails are not a very conducive environment to have those treatments for these people because most of them really aren't criminals. They just have a substance abuse problem or a mental health problem. And detention centers weren't built on delivering these services. So I think I have a really unique view because I'm kind of both feet in both directions. I do believe in treatment and programming, but I do believe in the public safety aspect because my job is the safety and security of the facility for the community. But I do believe in programs and treatment, but detention centers are not treatment centers or not hospitals. We do have in-house medical and mental health services, but they're in no way equipped to treat the people that need to be treated in a proper way. But what we do is we try and have innovative thinking and teamwork to do the best we can in detention centers. And we've had the pleasure of working with BHSD for the last several years through the RISE program. And I think I can't say enough. I know I met Nick a few months ago at a recovery day. We had a recovery day event at the park, and we had some of our RISE participants. We have an art program within the RISE, and they had showcased their artwork, and people were able to buy their artwork, and we placed the money back on the detainees' books so they could purchase hygiene and supplies. But I met him there, and I told him I couldn't say enough with our working relationship with BHSD and his staff, Tamara and Anita. They're very wonderful to work with. They really help us a lot. We've learned a lot. We've moved forward with the program. So we've been working with them for several years. I became warden of the facility in December of 2021. And I decided that RISE program is a jail-based program, so who not better to run it than the detention center admin. So we took over the RISE program in 2022 in April. And I also thought our in-house medical, we had a wonderful doctor that wanted to do a lot of different programs. So we were one of the first jails in New Mexico to start a MAT program, a medicated assistant treatment program within the facility. Also, what we do is we have a LADAC, an LSSA, and peer support to work with our individuals. So when an individual is booked into the jail, they do get an intake screening from our in-house medical and mental health services, and they're able to piggyback off to RISE so they could do an intake to RISE. Currently at our facility, we're able to have 15 RISE participants in our facility. And what our RISE staff does is they take the basic needs of each individual and try and develop a individualized discharge plan for that individual. And usually they work with them between 90 and 120 days within the facility. They have groups, they have individual counseling, we have an art program. We started a book club within the facility. I know during COVID it was hard to program, but we did do Zoom meetings for AA and NA. We also had several people that wanted to get back to their culture, their Native American culture, so we did do talking circles also through the Zoom, and that was able to help our participants. So now that we're kind of getting used to living with COVID, we're trying to up our programs. I know we've had yoga in there before, we had parenting class before. The thing about Grant County and Silver City, it's a small rural community, but we have a wonderful volunteer base and wonderful agencies that want to work and help that community. So one of the things we do is develop that discharge plan. That way we could treat the services that they need and be able to give them that warm handoff once they leave the facility to the MAT program, to counseling services, to a sponsor, to housing, to getting a license, to getting a social security card, to maybe getting disability. One of the things also that's new to our facility is we have a presumptive eligibility coordinator that's starting to work at the facility and is going to work with every inmate that's on intake, see if they're eligible for Medicaid, and that way get those services going. So when they walk out that door, they're activated so they could continue that warm handoff and continue that MAT program and continue those services and have the ability to cover it through their insurance coverages. So that's one thing that we're very happy to bring forth. And then looking forward also, with that whole aspect of today, we also have a RISE office within the community. So once somebody's released, you give them that warm handoff to other agencies. They do have a place to go if they run into issues or problems, whether it be the pharmacy or their appointment was canceled or they can't get transportation, because we are a rural place with transportation issues. So we do have a RISE office within the community that they could go to, and we have peer support workers there that could help them get them back on their feet, or if they're having a bad day, just be there for them to talk them through it, to get them the help that they need. So I think that's looking at the bigger picture of what the community wants to do at large. We're just trying to do our part within the detention center. So looking forward, what we've wanted to do is do some family reunification. reintegration, where we work with the families within that RISE program. And also, we do have a food program within Grant County that wants to work with us also to do the RISE participants and their family. We'd also like to piggyback with our DWI program, who goes into the schools and does education and prevention. We'd like to incorporate that with RISE and have some of our RISE participants that are through the program go with them into the schools and talk to the kids at the schools and just give them the reality of the situation and kind of walk them through that this is what I go through and we want to make this better for you. And I think as we get these RISE participants through the program and then follow them to the streets, we do try and follow them for up to a year to do stats to see if they come back to jail and not recidivate. So we do try and keep in touch with them. And also what we're trying to do is tell them to help them get jobs. We have Workforce Solutions coming into our detention center to help them get resume building, to help them get in jobs. Some of our actual people that have their own businesses are willing to hire those in the RISE program to give them that chance, to give them that start off to earning some income. That way they could follow up with probation, parole, and be compliant. We always look at new and improved ways to handle things. I will tell you that we're sharing our success with our RISE with other communities, with Luna County. We talked about our RISE program because we work together with other things within the jail. So they were able to apply and get the RISE funding also. So now we're talking to our next neighbor, which is Hidalgo County and Lordsburg, and we'd like to have the tri-county RISE program, maybe medical and mental health services. One of the biggest issues we run into is housing. There's a lot of lack of housing, especially for the homeless and those with mental health issues. Luna County, in looking at us for our RISE program, they came together and they're looking at developing a housing. I think they're looking at purchasing an old hotel and doing housing vouchers for the RISE participants. So what we're doing is we're sharing ideas and working together and developing this whole system within our communities. So we learn from Luna, Luna learns from us, and we move forward with the plans and moving forward on helping our community. And I think as BHSD is helping us work within the detention centers with the people in our communities, that's the beginnings of maybe the structure there and to maybe outgrow into the community, like you said, because we do have a RISE office in the community, but why can't that RISE office expand with working with the municipalities in the county and just expand to a center for everybody? You don't have to be within the criminal justice system, but just a community member that needs help, can't find a job, your kid's having issues in school, they're not with JPO yet, but we don't want them to get there, or they just can't pay their electric bill or they have no food. Why not have that one-stop place where you could have services or peer support workers to help with that? I do want to share some of the success stories. We've had several individuals with severe behavioral health and mental health issues through our work with RISE and through our in-house medical and mental health and other agencies within our community. We're able to help them, stabilize them. We had one individual that was homeless, had a lot of issues when he'd come in, and now he has his own apartment. He's attending college. We had another individual during our COVID who wanted to get back to her Native American roots, so we had the talking circles or through Zoom, and she was able to get back in touch with her Native American culture and then move back with her family up in northern New Mexico. We had another individual that he was kind of homeless and lost. He had lost touch with his family. He came into RISE, and now he's in culinary school. We had an individual that we had him help get into traditional living in Las Cruces, New Mexico. We did pay the first couple of months for the transitional living. She was having some difficulties in finding a job because of her background. So we're able to pay for another extra couple of months, and she did so well in that transitional living center that they hired her and made her help the accountant there. And now she's going to go represent that transitional living center in Washington, D.C. So there are success stories, and I think nothing's ever perfect, and there's always challenges and blocks, but what we always do is we kind of stop, take 5 steps back, refocus, and try something else and not give up. But I think we have a wonderful team in Grant County and wonderful different agencies working with it to move forward. And I'm really grateful for the RISE program and working with BHSD. And I really think that what we need to do is kind of look at spreading it throughout all jails in New Mexico and working with the state to make that a permanent program within the jails. Because I think if it starts with that program in the jails and every jail has that program, that's where you learn with all the individuals we have and the expertise we have on this panel, and you start working with the community leaders, the municipalities and the counties, and develop that community center and develop those programs like that. And it's just the inner working where you don't want to enter the jail, but you have the services within the jail, but outside of the community as well before they enter that criminal justice system.
And if I can just interject for a quick moment, so, you know, it's easy sometimes for us to bash legislators, right? They're easy targets sometimes, but I just want to recognize that this RISE program and Grant and Lincoln counties are two very successful programs. But this was something that was passed in 2019, and in 2020, when we started the program, we had 5 detention centers that onboarded. So next year, once we onboard San Miguel and Curry, we're going to have 14. So in 4 years, this has gone to nearly half of the counties across the state. And one of the reasons is because it's been so successful, the model, and getting community involvement, which is, I think, the other thing that we've been hearing over and over again. How do we link the community in? It is so very, very important.
That river, Raul, if I may.
Yeah.
That I'm talking about, so you see, and that's that linkage that's being pointed out. So there's another center, a detention center, San Miguel County Detention Center. And so we've got, you know, if 2019, we started the youth center concept, which is at a school that's summer, evenings, and weekend curriculum, access to 10 vital services. There's a Boys and Girls Club there at West Las Vegas. There is a Big Brothers Big Sisters. There is a Summer Health Career Academy. We have Quentin Ledger now has a music camp. You know, opportunities, not just sports after school activities, but all kinds of activities, youth mentorship activities. If you don't catch them in the youth center, by the way, we're trying to do one in Mora too. If you don't catch them in the youth center, then they land in a community health center. Carly was saying, Dr. Bonham, sorry, Carly, was saying, you know, back to this idea of the 60s of, you know, this kind of one-stop health center, right? And if you don't catch them in the outpatient community health center, you know, where do they land next? Well, they land hopefully in a residential treatment center. And that we're trying to do in San Miguel County as well. And if they don't land in that residential treatment center, they land in the detention center. And if you don't catch them there and get them back in, they land in the cemetery. And that, back to that word dead last, that all hits so near to us. We can all think of people that we love that have fallen victim to this. And so I think that's the connection to say those are not separate things, that all those centers have the same intent. And no one, back to 100%, is lost. Everyone has an opportunity. But the more we catch upstream, the less are going to flow into that detention center. And winning and cemetery, and winning looks like, you know, maybe we don't need so many detention centers.
Right. Yeah, I mean, I honestly, in my conversations with police officers and prosecutors, if you could put the communities and the entire state on a path where we had to invest less in detention centers because we're investing more in families that need stability and support on the front end, I don't think you will find any member of law enforcement that really objects to that. I think at times there is a tendency to have that conversation where it's a one or the other, right? One comes at the expense of the other. And I've always felt like that was a false choice, that we should be able to come up with a coordinated and integrated approach to improving public safety. But one of the things that strikes me about the success of the RISE program and the folks that you talked about being a captive audience, they are a captive audience. And to a certain extent, the families that show up at the community centers, the ones that exist, I think that's extraordinary, but one of the things that I worry about as a former child abuse prosecutor are what to do about the families who are not showing up at the center. What to do, how to find and help and intervene in a positive and successful way with the right kind of resources, with those 10 critical resources for those families. In other words, how do we ensure that qualified professionals are knocking on the right doors with the right services before you have to call the police or 911 for an ambulance? And that's something, that delivery gap has always been something that I have struggled with trying to understand. How do you solve that problem for the people who aren't showing up, but you know they need help?
I think it'd be a sharing of information amongst the community, because no matter what community you're in, somebody has knowledge of that family, of that issue, whether it be the school system, that the kids aren't going to school, or whether it be the local family doctor or the neighbor or JPO, or there's so many, or even the church, or even the aunt, the uncle, the grandma, or we do a lot of networking with CYFD. So right there's problems with, they get reported to CYFD. So there's always that sharing of information, which I think doesn't happen oftentimes, where the schools, CYFD, the churches, local community members just share that. And it resounds to me that it's going to take the whole community to help to prevent the issues in the community, and everyone's going to have to be a part of it. And I myself have neighbors that have issues, and I've tried to reach out for services with them, and they didn't really want to take it, so they ended up within the JPO system and CYFD system. But I think just the sharing of information and just caring about one another as a community and coming together as a community and helping those in need, and not giving that stigma of that person that has substance abuse problems or mental health issues or behavioral health in the whole outlook of it, because it's not just those that have substance abuse issues or those that are in jail, but like they were said on this panel, law enforcement, corrections, detention, medical and mental health. I think it's getting so difficult to do that there needs to be treatment for them to carry on their services, because it's a very rough issue. And I know some states, they have a mandatory 90-day mental health fit eval for all their employees, just to make sure how they're doing and giving them services. I know we do have an employee assistance program at the county that I encourage my staff to use, because it is a hard job and it is overwhelming, and you do get that burnout. And within the 20 years I've been doing this, I see the burnout happening a lot sooner than normal because of the difficulty of that situation.
And I think this goes back to what we were saying earlier about stigma. You know, we just celebrated the first anniversary of 988, and we've seen those numbers of people calling for crisis services go up and up and up each month. Now, we can make all sorts of correlations as to why this is happening, but the fact is that people are recognizing that they need to reach out. And the more that we remove that stigma, similar to, you know, when folks need family assistance, whether it's for domestic violence or child abuse, knowing that there's help available, we need to Joe's point, give them those resources and make those resources actually be resources. Just a very quick story. Last year, I had some surgery, I won't mention the facility, and it was major surgery because it was happening to me. If it was somebody else, it was minor, right? But the reality is that as I was sitting in pre-op with my wife next to me, the nurse said, do you feel safe at home? And I said, well, the person that's probably causing me not to feel safe is sitting next to me, right? And then I just asked also, what would you have done if I said, no, I don't feel safe? If my wife wasn't there and I said to you, what if I said, no, I don't feel safe? And she looked at me like a deer in the headlights. And we need to kind of, if we're going to do these trainings, make sure that they're connecting those dots as well. And that has to be in schools, that has to be in hospitals, that has to be in all of these places where people are going to go, where they potentially might be reaching out. So that if somebody says, I don't feel safe, whether it's because of parental abuse, whether it's because of elder abuse, domestic abuse, whatever it might be, God forbid, that they know that not only if they're going to report it, that they can feel safe doing it. And we can do a better job of promoting that. And that's not on any one particular part. That goes back to the community and us all going back to our individual spots and saying, how do we really promote this and make people feel that the resources are real and that they're actionable?
Yeah, can I just say the idea of the resources are real? You know, you've heard my rap in the first panel. Until those services are in place, we're not referring families to services, or at least 50% of the population. So once we do that, but I do want to get back to the question about, well, how do we like If we're talking 100%, how do we make sure everyone's in and nobody's out? So in our circle, 10 Vital Services, parent supports home visitation. So in the future, when a baby is born, there's a home visitor making a relationship with that mother and with that infant. And right there, there's a relationship. And it's like, and you're saying to Marie, so you're going home tomorrow from the maternity ward. Like, do you need access to these 10 services? And are you okay? I mean, that's one way we could start tomorrow, making sure that every New Mexican born is in the circle. As for those already existing today and damaged, traumatized, that's going to take, if we have our family center in the future, 100% family center, which is using technology to connect everyone together, at least all the providers, you suddenly have a very robust network. And in New Mexico, outside of maybe 3 cities, the smaller cities, everybody knows everybody. And they know the families that are disconnected and are alienated. And so we do know where people are, but we don't have enough staff to get there today. But in the future, we can do all of this if we have the political will.
And the workforce.
And the workforce.
One of the key things on this is that, so I've dealt with this in my primary care career for 20 years. Well, we can't screen for Hep C because what if they're positive? Who's going to treat them? We can't screen for depression. We can't screen for suicidality. We can't screen for, now we're supposed to be screening for social determinants of health.
Right.
So what if you screen positive that they don't have a place to live? Then what? I think that's back to what Nick's point is. And so for all of that, we need more workforce. And that becomes another kind of a root thing that we can do together. Again, Semillas de Salud, not just grow our own health professionals, grow our own first responders, grow our own educators, grow our own law enforcement, grow our own wardens.
Yes.
All of those pieces, we really need to grow a workforce, which is, again, if we do it well, grow your own workforce, that also means that we're providing opportunity to that bottom 25%, back to that concept of New Mexico rising, and saying that no one's left behind. Everybody has a chance. And maybe healthcare is not for you in the end. Maybe you'll want to, go law or go politics or whatever it might be.
Or
and
be a teacher.
or be a teacher. There's a pathway for everyone. And so I think that's a common ground that came up here. And if we build it correctly, it will not only be systemic back to that plan, because no matter what you talk about, the rate limiting for even fast food joints right now, contractors is we don't have enough workers, right? And so it's systemic in that way, but a generational impact. Because if we can bring up that bottom 25% of New Mexicans and their kids, especially their kids, right, then on that next generation, they'll be better able to provide those opportunities and have a better skill set to prevent those ACEs in their kids. And that's how, from a generational impact you're calling for, we can have a revolution.
Nick, I've got a follow-up question based on some of the things we've just heard, but also based on what Philip was talking about earlier. Part of my assumption is that people who are drawn to this work are drawn to it because they actually want to engage in the business of helping people, of providing services. No one wants to go into this thinking, I would love to do contract review or regulatory compliance or navigate Medicaid reimbursement rates or any of the other bureaucracies that are getting in the way. What can we do as people who have some impact over regulation and bureaucracy to provide for adequate oversight so that there isn't misspent resources, but also get the unnecessary bureaucracy out of the way so that Philip can get in the business of hiring another provider rather than a contract administrator?
No, I think that's a great question, and it's very valid. And I think anybody that goes into healthcare, much like in law enforcement, we're not going into that business to get rich. We're going into it because we want to help somebody. And our job as government, and this is going to be something, it should be to reduce those barriers, right? We should make it easier for folks to treat the people that need it. That being said, I think these are the conversations that we need to have, and I think it starts with having conversations with the provider associations and getting out of offices and going and sitting and saying, what does it take for you to bill for this person? Right? So you shouldn't have to get to, David's point before, you spend all this time becoming a PhD, and now you got to go get an MBA because you have to figure out the paperwork, right? Or to Phil's point, we have all these folks that want to help. Why are we creating a barrier to getting them certified? We have to kind of look at some of those things. So I think it takes, number one, dialogue on our part and being open to looking at that and saying, what is the right balance? And then working with the MCOs for them to understand what our needs are. And that we do, in New Mexico, we have very unique needs in the sense that we service folks that are in urban communities, suburban communities, rural, frontier, and tribal communities. And that each one of those have very different needs, and we need them to be responsive to that and hold them accountable, as opposed to making it more difficult for them to ask for reimbursement 5 times, right? And I think this is a place where, under our current administration over at HSD, we want to make sure that that's happening and have those dialogues so that we can sit there and say, get back to what we need you to do. And we also need to, just to go back to Matt's point, figure out ways to better incentivize folks to go into these professions, whether they're social workers, whether they're peers, whatever that might be. And let's not think of the traditional, we gave you X number of dollars towards your tuition. Maybe we could look at things like rent assistance or childcare, or how do we kind of offset that so that it makes it easier for that single mom to go to school? Maybe we need to look at childcare at the universities, right?
Willie Mae and Joe, you both talked about the success of the RISE program in each of your facilities. It also sounds like you partner with local groups, local nonprofits. Talk to us about how you identify those groups and whether you feel like there is stability in terms of the resources they have, or if you feel like they are scrambling for resources, because it's one thing to be able to provide these programs while someone's in custody, but I think the real challenge happens the day they walk out the door, because that's the risk that they're gonna fall back into old patterns and bad habits. And if they don't have that warm handoff, Joe, to your point, that's where we're likely to fall down. Do you feel like these local groups have the resources that they need and the staffing support that they need, or can the state be doing more?
I think we're lucky in Grant County and Silver City that we do have a lot of local agencies to provide treatment and care. However, I think the problem is that each agency is kind of siloed and not really communicating and working together. But I do know, as far as like mental health and also some medical, though, it's overwhelming, and it's hard to find providers to provide that care because it's a competitive market and you have people moving from this place to that place out of state. So to answer your question, I think yes, that we need to attract more providers to rural New Mexico. But I think that the agencies that we do have in Silver City are very wonderful and trying to work with us at the detention facility and make things better. The thing about Grant County is there's several towns that are kind of spread apart, so transportation is a huge issue that we need to look at also. We do have a solution working with RISE for the detention center transport, but once they do get home to that warrant handoff, they sometimes have trouble getting to that first appointment, which we also have to work on. Also with that housing issue, if you're homeless, there's not really much housing. I know that my ex-wife tried to look for a rental and she couldn't even find a rental in Silver City. That's how bad housing is. But I think, yes, they do need maybe more personnel to provide services, but I think that we're blessed in our community to have the services that we do have. They're willing to help and really go that extra mile. And what we do is we just kind of visit every agency within Grant County and sit down with them and tell them what we'd like to do, what our issues are, what their issues are. And one of the things the leaders in Grant County are doing, and they're having a lot of community events where they ask the community what they see and what's needed. So they are trying to find solutions. And also even our 6th Judicial Court is wanting to maybe try a mental health court also and different kinds of things. So we're all looking at the same goals, but we're all separate, trying to do the same thing. We need to come together and have a system and not have those overlapping services. And and kind of develop something to have that streamlined system where we're not over providing services, but we have that structure. And I think things like today are making that possible, and having those people that care, because I've always learned, just surround yourself with people that care and really want to help and are experts in the field, and you can't go wrong. But I think today is a really great start, but I also think you could always do better and try better and just work together to bring the community as a whole to have health and prosperity and peace, which I think we can do if we just learn to work together, not fight for services or not fight for that funding, and just do what's best for our clientele.
I totally agree. I'm kind of smiling because I'm thinking about some of the conversations I've had with some of the detainees. And one of the things that comes to my mind is that it's almost, in Lincoln County, they have a network of friends, their connection. It's almost like, you know, the underground or whatever. And people come into detention, they say, you know, I know so-and-so, and they're all connected in one way. However, the connection is a negative connection. It's more drugs, activities, criminal activities. And so I'm wondering is that how can we lower that barrier to where someone breaks through that barrier or that barrier there, and to have them start looking at, well, what about community engaging themselves or connecting themselves with community resources after they leave detention? Because the natural thing for them is once they are released, then they want to go right back to their environment. And I always tell the detainees in my group, I tell them, I said that we are all a product of our environment, and it's up to you to change. And you have to draw the line. Somebody in your family has to draw the line, and maybe it could be you. So those are some of the things that we talk about in group, and having them to stand up for themselves. And really what I'm talking about is empowerment. I'm really working diligently to to empower people that are incarcerated or that are detained right now. And I would like to see them really rise above all of that and to become successful. Are we going to be, is that going to happen 100% at a time? No. But I think that, you know, there's some small breakthroughs and people are doing really well. We have a lot of success stories too from our program. And people just want to be connected. They want a safe space to talk about their trauma issues, their hurt, pain, and trauma. And that's what we do at Lincoln County Detention Center. And then also too, finding out, okay, what are the needs? What do we need? What do you need? How can we help you? And connecting them with those resources. So we have, in our community, we have a community listing, and we make copies of that, and we give it to them, you know, food banks or all these other community services. That way they have it in hand when they walk out the gate. So those are some of the things that we do. And by the way, I forgot, I did put our brochure in the front, and it has some of the things that I talked about here at this summit.
Thank you, Willie Mae. So I want to take this opportunity to open it up for questions for anyone in the audience to follow up on any of the issues that we've covered in any of the panels. And I think it's really important to get the most out of their expertise. So if there are any questions.
Hello. Thank you, first of all, for bringing everybody together. My name is Barbara Luna Tedrow, and I want to come to you a little bit differently from a different aspect because I work in the early childhood field. And so I want to give you the magic lamp, and that is early childhood. You asked, what's the magic lamp? And that's it. And so I want to talk to you a little bit about, you know, when you talk about early childhood, we start touching families prenatally, through home visiting, through childcare. New Mexico right now is serving over 27,000 families with free childcare. And these are going to high quality licensed centers. So when, you know, I myself, I've got 4 centers in Farmington. I serve 550 children daily. When I talk about ACEs, the problem that we have is that we don't train our staff. We have qualified staff, and they know how to teach the children. But these children and families that come to us come at a different level. They come to me with their everyday problems. They look at us as their mentors. When they come to me and say, Barbara, I can't buy food. Barbara, I don't know how to pay my utility bill. My directors and myself sit with families and guide them, and my teachers. And so when we have these children coming to us, we can stop so much of what is happening and what we're talking about here today. And it won't be tomorrow because we're talking about the children. And then when these children, I can help them and they don't have to, they can get the services they need. I can have every child care center should be doing an ages and stages questionnaire on their children. What that is it's an assessment tool. Only nationally accredited centers are required to do this. Every center and every child should have access to this in the state of New Mexico so that we can be assessing where children fall and what families need help with. But we have to get the training to the teachers. There's so much money. So I'm asking that we need to take a look at what is ECECD doing with their budget and where are they putting the proper dollars? They need to be putting it towards training, to helping my teachers, help the families so that I can keep them from ever having to talk to a police officer or ever having to go to a district attorney's office.
So we got a lot of information about poking holes at what the problems are and kind of what the solutions might look like. But I didn't hear really necessarily anything that said this is a solution that we need to try. New Mexico is the worst in the nation for ACEs, which means to me that 49 other states are doing it better. Have you guys looked at other states to see how they're addressing these? Are there any concrete programs that are showing proven results as something that we could implement now based on something else rather than just having a conversation about what the problems are and what we'd like it to look like? What programs are working in other places?
So I have a sneaking suspicion that Dominic might have some ideas about this. So I'm going to let him elaborate on some of those issues. One of the things that I will tell you from my own perspective is, and I think people have seen some of the public dialogue and conversation about the interest that we had in establishing a civil rights unit inside the Attorney General's office. The primary focus of that unit was going to be on the securing the rights of children. So to Dominic's first question, yes, the children of New Mexico have constitutional rights to basic safety. And some of the basic access to resources and healthcare, but that requires adults in positions of authority and responsibility to recognize when there are serious deficiencies in specific programs and address those deficiencies. And I'll give you one example, because it kept coming up not only when I'm thinking about the people that are coming out of the detention center as adults, but in trying to serve families that are impacted by all of this trauma, intergenerational trauma. If an infant is born in one of our hospitals and we know they are drug addicted, it's not a policy failing, it's a moral failing to send that child home, back to a home where we know they came into the world addicted to drugs, and to hand them a care plan that says, maybe you should do this. Whatever else is going on in the world, and wherever no matter where you are and sort of the journey on recovery or addiction, those other things, that baby did not choose to be born into the world addicted to drugs. And we have a moral obligation to make sure that they get the treatment that they're entitled to receive. And there should be broad consensus on that. And it should, in my judgment, not be optional. It should not be optional. This is not something that if you feel it's necessary for a child to get that kind of care, maybe this is what you could do. No. That child deserves more than that. And look, we have a federal law in place, we have a state program in place, and we have children dying. And we are sending them back into homes that are, we know, impacted by substance abuse and trauma. And I don't want to stigmatize anyone. I don't want to make new mothers who are struggling with their own substance abuse issues stigmatized in their community. But it is unacceptable to send that infant back home to a home where we know it's unsafe. And we know they're very likely to end up in a referral to CYFD again or end up dead again. And that's an example of a moral failing that we have to address. We have to hold ourselves accountable. And so with that, I'll turn it over to Dominic for a much broader sort of array, I think, of policy ideas and solutions, because I know that there are other states that are doing creative things when it comes to adverse childhood experiences.
Yeah, I mean, I think the first. Yeah, I think the first place we go is to data. I think your question is excellent. We have 50 states. Think of them as 50 social experiments. Experiments in taking care of our most vulnerable populations. So Anna E. Casey Foundation puts out the Kids Count report. So they look at many indicators related to child well-being, and they rate every state. And so they're looking at health, education, everything we care about in this room. And so I would go there first, just to see, like, well, where are we at? And we're 50th, we're last, and we're usually always last. Sometimes we compete with Mississippi, but we tend to get it back. And people joke about it, otherwise they'd cry about it, because we seem to just be trapped there. So that can get a little bit to your question of, well, what states are doing better? So when I looked at the Kids Count report probably 7 years ago, I looked at the top 10 states that they rated as the highest, right? So what are those states doing that we're not doing? And this would be a very long conversation, but I think the good news is this: if you're real, I'm sure you are very interested, there's all the research in the world out there on what you do, back to the social determinants of health. Some states invest more in this and others don't. And so it really comes down to that. And I do have to piggyback on what the Attorney General said about systems. When we talk about, a behavioral health care system in New Mexico, we don't really have a system. We have private and public organizations that are siloed and kind of do their own thing. This is not Sweden, where they have a universal healthcare system and they have they use the World Wide Web to track everything and share information. So there are 20 countries that have universal healthcare, which means they have a system of behavioral healthcare, medical care, and dental care. So that's a whole other conversation. But when I talked about our 10 vital services, these are 10 systems in every county that aren't necessarily talking to each other. And within the system, they may not be talking with each other. And even within an organization, they may not be talking to one another. So our opportunity here is to really increase the idea of we're in systems, we talk to each other, we share our challenges, and we share our solutions, and we ultimately do get to a vision. So I don't know if that gets exactly at where you want to go, but I think that it's a really good question to look at what are other states doing. And there's something called, diffusion of innovation, which means if they're doing something great in Connecticut, let's bring that here, right? Let's share it. If they're doing something great in Lincoln County that's not happening in San Juan, why don't we bring that over? Once we start building, I can tell you about the future. There's a lot of talk within the legislation body about the 100% family centers. So there is real interest. That's great news. And if things go well, there will be a few. And all we need are a few. Because I guarantee you, once 3 are up and supported and evaluated, every county will want one. And then they will become the base of operations, then to build out to the schools and other centers that then do this work. So it's all, I keep saying it, it's sitting right in front of us, right? None of this is brain surgery. It's an opportunity to look at research, to look at data, and then to have, once again, back to the political will, to say the past was the past and the future is a place where 100% can thrive.
And if I can just add also to your question, I sit on a monthly call with my counterparts across the country, and we talk about things, whether it's behavioral health in prisons or in different settings. And, you know, the things that I hear, you know, make me go, you know, we're not alone because everyone's trying to tackle the same thing. And what can we learn from them? When someone says, just to pick on Connecticut again, they're not here, it's okay. You know, when they say, we tried this and this is the snag that we hit, I take that back to our team and say, let's make sure that we avoid that, right? And that's gonna be the things that we need to learn. And I agree with you, I think that, you know, we really need to look at early childhood, but those numbers are gonna take a while for us to actually see that change. My point of the magic wand or magic lamp is that we shouldn't fool ourselves into thinking that we're gonna go from 50th to 17th overnight. And we need to commit to this and have ongoing conversation, not just here, now, what does that look like? The last thing I'll just say very quickly is we're trying to build that system now, and we're calling it the crisis continuum. Dr. Bonham had to leave early, but she's part of that conversation as well. We're rolling out things like 988, and how does that talk to groups, mobile crisis teams that can respond in a crisis so that it doesn't escalate to a bigger problem. That's going to be an ongoing project. We're going to be rolling out 2 teams within the next several months. And we're looking at the behavioral health clinics that are going to be certified to kind of do some of those things to get away from the 60s model, but also having those ongoing conversations with the other components, such as residential treatment centers and IOPs and so forth, so that they're all talking. So if, you know, if I'm in recovery and I feel that I'm having a really bad day, that I don't feel like I have to start all over again, or where do I go from there? And that's what we need to build out better and make that more connected. And my hope is that, you know, right now we have a couple of teams and a couple of programs that are doing this and this and this. But once they see that this is working and we can iron out the kinks for them to do their billing and their administrative stuff so that it's not a burden to them, others are gonna follow suit. Nobody wants to be the first, right? Because that's how you get a disease named after you, right? It's, you know, you wanna be the person that says, okay, I saw that, I'm gonna learn from that, let's move on, right? So we're gonna get there. It's gonna take some time and patience and a lot of blood, sweat, and tears on our part, but I'm committed to doing that. And, you know, at this point, I don't have much more hair to lose, so, you know, I'm all in.
I think Nick really touched on something that's important, which is this is the beginning, or not the beginning, this conversation's been happening for some time, but this is going to be a long and complicated and intensive effort. It has to be if it's going to be successful. And we didn't get to this place, right? A lot of times we think about New Mexico and where we stand on these lists. And we have to understand something about our history. This is a place that historically has had a lot of violence in its past, a lot of poverty. A lot of the social determinants of health that have been at play here have been at play for centuries. And it is not going to take us centuries to dig out of it, but it is going to take us a long time. And one of the things that our political system is not well engineered for are complex problems that require long-term solutions. But there is no escaping that reality. Right? And I say that as somebody who routinely gets called upon to talk about the acute public safety crisis of today, right? There will be a case, there will be an issue, and we will address it. And I have talked about acute and emergency failures that I've identified inside the criminal justice system. But that is not the only aspect. In fact, it's the thing that we need to do right now to deal with the emergency that's right in front of us. But if we want to solve this problem, we have to engage in this work. We have to be able to scale these, identify issues, scale solutions without adding layers of bureaucracy. breaking down silos without stamping out local innovation and local voices and people who are committed in understanding their communities. And it's, the point of today's conversation is it's going to be complicated, and it's going to take a generational commitment to solve a generational problem. But if we have that perspective, you know, we've heard from lots of different people, what you should come away with is there are people who are committed to this work right now. They understand their communities, they're willing, they have ideas to offer. We need to figure out ways to support them, to start including them, not because they're just dealing with public health issues. This is a conversation about public safety. This is a conversation about public safety. And for far too often, we go into these legislative debates, right? And we'll have a conversation about behavioral health, but we'll have it in the health committee. And on the other side of the Capitol, you'll have the cops and the prosecutors, and we will be getting asked, why are our streets so unsafe? And somewhere else in the building, we're talking about the failure to invest in and protect children. And what I can tell you is that 9 times out of 10, when I have identified a violent felon in my community, it's usually a child that has been failed by this system 15 or 20 years ago. And we will, at that moment, do what we are expected to do and do our best to remove that person from the community for everyone's safety and for everyone's benefit. But it would be beneficial to us all to find that child long before they pick up a gun and threaten somebody's life. And if we're serious about tackling that problem, then we have to look at it over the long term. So with that, I want to thank everyone for being here. I want to thank my panelists, and I really, really appreciate your engagement and your hard work. Thank you so much.
Okay. Yes.